for our national anthems, please. We may take our seats, ladies and gentlemen. It's an honor to have this partnership day. I want to first of all commend you for the patience you've had with us since we started according to our schedule. If you want to follow the program, kindly where you're seated on that very placard on your table, the QR code, when you scan it, you'll get the program today. The QR code is just right on that small material on your table. It will be in position to give you how we're going to run today. My name is Andrew Chamagedo, and we're very honored to have our chief guest, Dr. Charles Olaro, the Director, Curative Services, Minister of Health. Let's give him a round of applause. We are very honored to have you, sir, and thank you so much for joining us. He came through with the Assistant Commissioner, Maternal Health, that is Dr. Richard Mugahi, is equally here with us. Good to see you, sir. Thank you so much for coming. We're celebrating 30 years and the roadmap of Marie Stopes as partners today. Last year, the Ministry of Health recommended and recognized the Marie Stopes Uganda as the #1 SRH organization as part of the implementing partners with the Ministry of Health. The focal area, let's clap for that. Being the #1 does not come easily. So the focus points of Marie Stopes Uganda, it has been FP, where I happen to be the national male champion of family planning. I believe in family planning. They have cervical cancer, screen testing, the STI management. We have post-abortion care, and they have now extended to maternal health. And with this, they have a hospital in Lugogo for the women. How many of us have been at the Lugogo Women's Hospital? We should visit there. We should visit that hospital. It's very good. Let's clap for that hospital. I want to commend the management of Marie Stopes for such a great extension. Marie Stopes has the biggest concentration among the vulnerables in the areas that are rural and the young people, and they're dealing with quite a lot of partners, especially the local government, and at the national level, they're dealing with the Ministry of Health. In a special way, allow me to thank our implementing partners. I'm going to mention a couple of those I have, and as and when others join, kindly my team at the entrance, you let me know. And for the rest of us, I'm going to request that we are going to clap for these development partners. First, we have the FCDU, formerly was DFID, the UK aid. Let's appreciate them. Those are our great development partners. We have UNFPA, we have Netherlands, we have USAID, we have Danish, Norwegians, we have CEDA, Blue Hills, and Bergstrom Foundation. Let's give them a round of applause. Now, those have been very, very critical in a couple of things. And I want to take you through a couple of pillars that have actually made the journey of Marie Stopes much more stronger and great. One of the pillars is leaving no one behind. The issue of inclusion, they're very pertinent at it, and they have mastered this. And with this, they have partnered with the public sector in terms of outreaches. We have seen the mobile vans in the different areas. To those of you who come to the ground in the communities, you've seen them. Then the second pillar has been strengthening the private sector provision. Now, the services here are free for the clients. They have improved the quality, competence, and customer care and adherence of Ministry of Health standards to those in the private sector. Their third pillar is social marketing. Here, Marie Stopes Uganda has made sure that the healthcare services to the people who can afford, people like you and me, who can afford to pay for the services at the Lugogo Hospital, who can afford to pay for vasectomy, people like you, Marie Stopes has done that as their third pillar. But this has been very strongly done by regulating the pricing of the services and the products. The fourth pillar, it is the funding of the mission. They have gone ahead to look for partners to enable them make these services affordable and accessible to the last mile structures. And that's where we thanked the development partners. When it gets to partnerships and advocacy, Marie Stopes has strongly lobbied an enabling environment for service delivery. And this has been done with the help of other implementing partners. One of these, it's the district local government. Let's clap for the district local governments. We appreciate you so much. And we have other implementing partners, Makerere School of Public Health. We have FHI 360. We have Rahu. We have SRH Alliance. We have CARE International. We have Plan International. We have PSI or PACE. We have Reproductive Health Uganda. We have PATH. And then we have Pathfinder. We have Save the Children, USAID Rights, that is Uganda Health Activity. And we have the Family Planning Authority, not forgetting the National Drugs Authority, National Medical Stores, and the Joint Medical Stores. Friends, the other very last pillar is the transformation of the organization. Over the 30 years Marie Stopes has been in presence and in service of our country, they have evolved. They have embraced technology and innovation in terms of acquiring information and disseminating information, capturing data and reporting it both at national and at local level. There is quite a lot that has happened in the last 30 years. But given that today we are partners, allow me welcome our country director, our senior country director, Dr. Carol Sechimpi, to welcome us in a special way and possibly shed for us the kind of picture we ought to see in the coming years. Let's welcome Dr. Carol Sechimpi.
Thank you, Andrew. Our guest of honor, the Permanent Secretary, Minister of Health, represented by Dr. Charles Solaro, distinguished representatives of the Ministry of Health in your various capacities, members of Parliament present, representatives from international development community, fellow implementing partners as listed by Andrew, our dear colleagues from the field, district health officers, health workers in your respective capacities, my colleagues from Marie Stopes, ladies and gentlemen, good morning. Thank you for coming. Thank you for braving the rain and the potholes and the traffic, really in the spirit of partnership. We appreciate you for being here. Our theme today is strengthening the public sector for sustainable investment in sexual and reproductive health. You have our annual reports on your table, and in there, as Andrew has touched, we detail a bit of our strategy, which is named MSI 2030. This is the third year of implementation of that strategy, and our vision is bold, really bold. We want that by 2030, every individual who wants it will be able to access contraception. Our approach is context-specific, and it is co-designed with the Ministry of Health and the communities where we serve. Our bottom-up partnerships have been catalytic for accelerating access in uptake. In 2022, I'm excited to report that MS Uganda is estimated to have met 40% of all of the national family planning demand. Our public sector footprint spans more than 600 health facilities in 90 districts. Our 21 mobile outreach teams crisscross this entire country, complementing that effort and delivering services where health facilities will not reach. So today we're very excited to share our vision for strengthening health systems and some initial learnings on what we think it takes to expand access where it really matters. That is for young people and those in marginalized communities. Much of our journey to leave no one behind has been influenced by the FCDO. It is FCDO's PMD program that first pushed us towards our work to engage young people. It is also the FCDO's PMD program where we first started examining the evidence of how or whether we're really reaching the poorest. And that's something that we continue to do for all of our programs. Today, through the RISE and WISH programs, FCDO is the largest funder of our health system strengthening work. Let's clap for FCDO. But it's not just FCDO. There are several other partners who are contributing to this cause. MSI, our parent organization, which is headquartered in London, is contributing to this cause through our Global Investment Fund. The UNFPA, with funding from Netherlands, Norwegian, and Danish embassies, are also supporting us to do similar work in West Nile and in Eastern Uganda. Yes, Betty, you should clap for them. And through the UNFPA programs, we have evolved further to extend our interventions beyond just family planning to broader maternal health. Bagstrom Foundation and several other private foundations are also contributing. Dr. Ndamaje, thank you for coming. And most recently, USAID through URC's Uganda Health Activity will also support this effort. So when we say we're leaving no one behind, exactly what are we saying and what are we doing? We continue to go beyond the last mile to bring contraception beyond the health system to those who would otherwise have no access. Evidence is key. We use our data to reach the most vulnerable. We will continue to deliver mobile outreach while diversifying and tailoring our approaches to reach both the urban and the rural poor. We continue to tailor our behavior change strategies to address social norms that prevent women and girls from accessing SRHR services. We continue to establish public sector partnership models that will transition towards national SRHR ownership. That way, we can ensure that in the long term, access to SRHR will remain for our communities in which we serve. My colleague, Martin, our head of programs, will shortly detail our public sector strengthening approach and how it has evolved over the last 5 years. We are increasing adolescent reach as we know the profound impact that our services has on young women. We're immensely proud of the work we do on adolescents. We have doubled our adolescent reach from 6% of clients in 5 years ago to 15% of all of our clients today. We're continuing to learn how better to reach young people through human design, center designed work and testing new services and products to expand our offering. We are expanding the integrated nature of our services to include menstrual hygiene, HIV, HPV, STI, cervical cancer prevention and treatment, and maternity services, as these provide an entry point for women into family planning. We continue to leverage our nationwide footprint to support the Ministry of Health in response to emerging public health issues, as we did with COVID and Ebola. The other leave no one behind areas where we work but have opportunity to scale up. These include serving the poorest in humanitarian context, meeting the needs of people with disability, and also addressing the issue of gender-based violence. Indeed, whereas we have achieved much, there's much more to do in order to ensure sustainable access to sexual and reproductive health for Ugandans. And this is really why we're here. We have invited you here to celebrate with us the progress that we have made, to share our insights and aspirations, but most importantly is to invite you to journey with us to deliver a very ambitious goal, which is that by 2030, every individual who wants it should be able to access contraception. In closing, I want to take a moment to acknowledge my team, headed by Dr. Peter Dungu, who's going to wave. And they're all over the place, and you see them well labeled in our logos. And I acknowledge them not just for putting together this event, but for going out every day to deliver the impact that we now celebrate. Thank you very much, team. Thank you very much, ladies and gentlemen, and I do hope that you enjoy the rest of this engagement.
Thank you so much, Dr. Caro Sechimpi, our country director. In a special way, I have seen Dr. Grace Chiwanok has joined us, who happens to be the ED of Uganda Healthcare Federation, where Maristop subscribes. Let's appreciate her. She's here with us. Thank you so much for coming. That is our umbrella body that takes all of us here. In a special way, allow me to welcome Martin Agaba, the head of public sector strengthening, to give us the evaluation of the MSGU PSS journey, that is 2015 to 2023. Let's appreciate him as he comes.
Yes, thank you so much, Mr. MC. Good morning, and protocol observed. I'm Martin Agaba, head of programs, Maristops, and today I'll be taking you through our public sector strengthening journey. We have come from far, but I think where we are good to show you where we have come from and what we have done and where we are continuing to go. Sorry. Okay. Sorry. I think the mentor didn't do it very well. Yeah? The green one, okay. Presentation down, and even this, when I'm in this corner, you can't read this. It's better I sit, I stand here. So we have moved a long journey since 2015. As most of you are aware, at first, Maristops we used to reach out to communities using outreaches. And of course, there are many things we kept learning as we do evaluation of our support to communities. And most of the important thing that the providers we used to interact with, they had a big concern. You are doing this work. We appreciate the quality of services you provide. and we really appreciate so much the contribution you are making. But the question has always been, what will happen in the future if you happen to go? We feel we would like also to reach a time and start doing the work like how your teams normally come and start implants, do remove IUDs, provide the counseling. How do we gain from this? We started it using our outreach team, but for most of you who have visited outreach sites, we normally create high demand and create awareness, and there are always many clients. So our teams could not have enough time to mentor these government providers on how to provide quality services. So in 2015, we piloted a model where we recruited nested providers embedded in the government facilities, and we are Maristop staff. And their role was to ensure that they provide services, but they focus so much on building capacity of providers to provide quality services. And the challenge came somewhere in the middle because of limited staffing within the facilities. These Maristop staff ended up becoming facility service providers. So when an evaluation was done, we found out that the service provision was going on well by Maristop staff, but when it came to building capacity for sustainability, it was a bit challenging, and the focus did not go much on mentorship, but went much in providing services, and even providing services, it was being provided by Maristop staff, which was compromising the component of ownership for sustainability. So we sat down, Maristop did an evaluation and said that we need to think twice and design a model where we need to ensure that we build the capacity of providers to be able to provide services, not necessarily the Maristop staff being the one to provide services. So in 2018, we piloted a model where we recruited a Maristop's trainer and paired with a district trainer, a government trainer. And they do a joint work plan, visit a facility, identify providers to undergo training to ensure that they build their capacity. The model of this training is competence-based and low dose, high frequency. So competence-based, it means that they go to the facility, do competence. If a provider is going to be trained in implant, you first do competence assessment. If a provider is level 1 in insertion of implant, you don't need to train that provider. If a provider is level 2, 3 in insertion of IUD, focus on gap filling, not necessarily training this provider who is already knowing how to insert an implant. So that's why we call it competence-based training. The importance with competence-based training, it attracts so much providers, they pick interest because they see value addition, and they see that you've come to fill a gap that exists, but also it minimizes wastage because you are going to invest where investment needs to be invested. So in this approach, we have seen many results, and of course, first of all, providers are trained, they are providing services, and the district trainers are engaged to train their providers. And as time goes on, we have moved the stage called where we have what we call indirect support. Indirect support is where it has been supported by a Maristop staff and district trainer, but has reached a stage where you need to leave it, government trainer or this trainer to continue training and conducting continuous support supervision, mentorship, without necessarily Maristops being in present. And at the end of the day, for us, we normally do a work plan to do spot checks to really see whether the impact created has been able to continue beyond Maristop support. And this has been going on very well, because in 2021, we moved 70 facilities to be supported by district trainer without necessarily MyStops being available. And you'll be seeing good stories from those facilities. And for 2022, we've moved to 125 facilities that are being graduated, and they are being supported by this trainer. What we need to know is that in this process, or in the model we have, it is evidence-based model, which you will be hearing from different stakeholders, beneficiaries, how this has really helped them so much. So how do we do this? There are many learnings we picked from the dedicated service provider model, reason being that during that time, we had the challenges of doing things thinking that we know everything. But at the end of the day, it was compromising a component of sustainability. So for this PSS classic model, when we reach, before we enter facility, we engage districts and Ministry of Health to ensure that we have inception meeting. During inception meeting, we are able to discuss with the stakeholders, more especially district leadership, engage them to be able to be the ones to explain what it means and ensure that we show them why we need listening their districts of support. At the end of the day, a memorandum of we sign a memorandum of understanding where the district is able to commit what they are supposed to be doing and also commit what we are supposed to be doing. So at the end of the day, we are able to do this capacity building jointly without necessarily being a MyStops thing, but a district-owned approach or model, which we want to ensure at the end of the day, we build a sustainable capacity. Facility level, we ensure that the district and the facility in charge is fully engaged and selecting which facility has gaps, the gaps we are looking for to fix, which facility has never been trained, because we know there are other partners that do this kind of training, so we don't need to be in every facility, 5 partners in one facility doing the same work. So we do together that mapping, baseline assessment, and ensure that where we take this capacity building is where the gap surely exists, and ensure that there is also value for money. The approaches in our system strengthening fall under different categories. One, as earlier mentioned, is the competence-based clinical training that uses low-dose, high-frequency approach, where we don't need to be in a facility every day. Go there, conduct mentorship, and leave the provider to continue practicing. Then go back after 1 month, continue engaging the provider to see how is she transferring the skills gained to serve the clients while providing the services. But also, the most important thing which we normally pay attention to beyond providing clinical aspect is what we call VCAT. When it comes to family planning services, we have what we call attitude. You can find attitude at community level, at leadership level, but also at service provision level. And that's at the end of the day affect provision of quality services. You find a provider who has bias maybe in provision of services to adolescents, a provider who has bias in providing maybe IUD to clients. So we ensure that the value clarification and attitude transformation is integrated in our FP mentorship, so that the providers' attitude is transformed to ensure that they serve clients without any bias. So from there, we picked learnings. During our DSP model, our focus was much on FP service provision. But we asked the question, if you mentor a provider, and this provider doesn't have commodities to support service provision, how is she going to practice? If you mentor a provider who doesn't know that documentation and reporting is important to inform decision-making at leadership level, district, Ministry of Health, what kind of contribution will be making? So we ensure that we do a wider system strengthening. So supply chain management is integrated in our on-job mentorship. And our area of focus is supporting providers and stores people to ensure that where the gaps exist, we support. One, the most important thing has been on documentation. You find a store has stock cards, but they are not updated. You find providers pick commodities from maybe supplies and commodities from the store, but you cannot track how the commodities are moving. And that has been a challenge because at the end of the day, you find a facility when they are making orders, they are either making orders and you find the facility is overstocked or understocked. And at the end of the day, it makes the decision makers have poor planning, and they also do not like a facility where well stocked and affect service provision. So we have ensured that we support supply chain management for productive health commodities to ensure that the facilities quantify, forecast, and order for commodities and consumables that they need to support SRH services. And for people from ministry, to remember that we supported the of reproductive health supply chain management, but also looking at the RH spas. And previously we had the malaria spas, but in 2019, Marispo's piloted RH spas tour. And we started rolling out in some facilities, and the time came when the ministry wanted also to ensure that we have RH spas. And Marispo's contributed great. It was a resource because we had already done something, and our team was very resourceful in contributing to developing the national RH spas, which has now been fully approved and rolled out across all facilities. And we have been in forefront of supporting the rollout of this tool. So really, that's part of our contribution in strengthening the public sector when it comes to SRH services. Then for data, for people who moved out to see what our teams have been presenting, we have been supporting so much in terms of strengthening the data quality. As earlier mentioned, that the component of data, if you do a lot of work and it is not documented, reported, it affects planning and decision making, including budgeting. So the component of data has been given much attention. We have built capacity and worked with the district structure to ensure that data quality is given attention. Our M&E team normally go to the field, work with district biostats to conduct in-depth data validation and data quality assessments to evaluate how the facilities are documenting, reporting in approved HIMS tools. And this work has been going on very well because we realize that some facilities previously maybe they were over-reporting or under-reporting or not reporting. But we've seen in these supported facilities, the quality of data has continued to improve as we continue engaging the stakeholders, and we hope to see this strengthened further in other facilities where we have not been, we have not yet reached. Then we have what we call the demand generation part. Our approach has earlier stated that we work within the existing systems, structures, identify gaps, and we focus on filling that gap. We don't move with Maristop's way of doing things and we embed them in existing structures. No, our role is to support what is already existing, work together to identify the gap, and we fill that gap to make it better. So the demand generation party, we have been working so closely with VHT because a facility A has been identified, providers trained, it has commodities, it has consumables, it has everything available. So what is needed now is a community to be aware that such a service exists. And we are working through the VHT structure to engage them to create demand and engage communities to sensitize them, address misconception about family planning services, and ensure that the clients are fully prepared to walk into the facility at any time to access this service. And this has really been going on very well, and we appreciate the VHTs for the work done. And please, we want to work so closely, and we continue to work through our SBC team to support VHTs to continue creating demand generation for the services at the government facilities. As earlier mentioned by Dr. Carroll, we have moved a long journey since PSS started. The classic PSS started in 2018, and now we are in 2023. So far, we have covered a total of 605 facilities by end 2022, and our ambition is that in 2023, we are able to support a total of 650 public facilities. And in 2020, during our supportive supervision in the Soroti district, we visited one of the facility, and we realized that one of the provider raised a concern. And this concern was about that they receive many clients who have had miscarriages, and this is an emergency service that needs urgent attention. But sometimes the biggest challenge that they don't have skills and to support addressing those. So what we did at the end of the day, this client was come breeding, wants an urgent attention. They still go ahead to refer them for further management because they are not in a position to support. So we sat down, we said, we need to pilot something regarding how we can build provider skills in provision of post-abortion care. So as the MSI, we worked so closely with the Ministry of Health leadership, and we piloted in this provision of PAC in 25 facilities. We trained midwives. Those that had equipment but didn't know how to use them. So we trained them how to use them, and supported them, and all facilities were well equipped with consumables and medicine and drugs to provide this kind of services. But the challenge was on skills. So we trained providers, they started providing these services. And we have started seeing good results because midwives in these facilities are well equipped, they are well trained, they have skills, and they can testify. They are now providing this kind of services. So we have now continued to scale up using the learnings from those from the pilot. So for 2023, we have an ambition of supporting over 70 facilities on PAC mentorship. And we hope to have this scaled up as we continue to pick best learnings. Public health workers have so far in the 22, we had 1,235 health workers fully trained and competently assessed and competent, confident in provision of quality FP services. This is a journey we have made, and we ensure that these health workers are supported by district trainers, MALSOP staff to continue providing the services that they are supposed to be providing. Our mission in 2023 is to support more than 1,350 health workers on mentorship. As earlier mentioned, facilities, we need to continue preparing for sustainability because as earlier mentioned, we have appreciated many donors, but projects have a beginning and the end. So we don't want a situation where we pour out, then facilities start struggling how to continue. So we have, in 2021, we piloted 75 facilities that moved to indirect support, and they are being supported by this trainer for continuous support supervision, mentorship for those who have not been mentored, more especially new providers. And whenever we read a spot check and visit, we find these facilities have continued moving the way they used to do when Maristops used to be there with these trainers. And this is really good news that there is a component of sustainability. And for 2022, we did 125, and our ambition for this year is to have 1 IT facilities move to the hands of districts to continue supporting them, so that we are able to add more on this kind of support. So far, we are in 96 districts with this kind of model, and in 10 cities in Uganda. So this is a graph showing how the performance in the facilities where this model has been taking place. If you can observe between 2018 and 2019, that's when it was starting in those facilities, and the providers had not yet gained so much skills in provision of service, and hello? The slide has gone off. So you can see that during that time, when you see the graph, as we add facilities, the productivity continued to go higher with the number of FP grants annually because of providers' competence and the confidence in provision of quality services. But also, most facilities have been well supported with the availability of commodities. Because, you know, with the one facility, one warehouse transition, it has helped the facilities to be able to quantify and order for their commodities. However much there are some challenges, but at least you find most facilities are fairly and adequately supported and equipped with commodities to support availability of services. And with demand generation also continuing to be supported by VHTs, the clients have really gained the confidence, and they are now aware that the services are available. They do no longer need, they don't need to wait for implementing partners outreach to come to access these services. They need to ensure that they are aware that clients, providers are well prepared, they have skills, and they can walk into this facility and receive quality services like the one they normally receive from outreach teams. This is another important graph. When you look at between 2018 and 2019, services were going on, but when you look at a couple years of protection, they were almost moving at the same pace with the number of FP services. But because of providers gaining skills in the provision of long-term, and more especially long-term have a high CYP factor, you can see the graph for FP is continuing to grow, but the CYPs are continuing to go higher because of improved method mix. So we need also to appreciate that when this model starts in a facility, most facilities, you find most providers are focusing so much on provision of short-term due to lack of skills, most especially in counseling and provision of long-term. But when we engage those ones after baseline assessment, their skills improve, they become confident, they become competent, and they're able to provide quality services and improved method mix. Yes, this is another important graph which demonstrates value for money, but also what we call efficiency and effectiveness in delivering such kind of model. PSS, when we started dedicated service provider, It was one of the expensive model which how much PSS is donor supported. I think most donors, whenever they could peep there, it was not an easy model to really support, most especially when you are depending on, I need support. Someone needs to look, which kind of support do you need and how much do I need to invest? So there's what we call cost per CYP. What do I need to invest to generate one CYP? So during dedicated service provider model where we used to have multitude of staff embedded in government facilities, this staff, you are paying salary, you are paying allowance, you are doing what? It was one of the expensive model which was not demonstrating sustainability and the effectiveness and also value for money. Because you could generate little CYPs, but you invest a lot of money. During that time, you realize that our was above 3 pounds. And when you calculate, you see it's average, it was a lot of money. So when we moved to classic PSS model, we realized that our investment, you could do, you invest at the beginning because you have the district engagements, some facilities maybe you have done a needs assessment, those that maybe had equipments, they are not enough, you need to go do some buffer. But once you've started the facility and the facility has started moving on very well, we have seen the cost continuing to go down because we have now reached the extent of delivering one CYP in that facility, one CYP costing 0.6 pounds as compared to the time when we had the other model that costed over 3 pounds to deliver one CYP. So this shows that this is a model, even if you have little funding, you can still support many facilities, build their capacity to reach out to the communities that need this kind of support and ensure that you create an impact at community level while you are investing less money. So as we implement this model, we normally go back to beneficiaries to ask them and evaluate and hear from them. We have, in 2022, we did a survey, and part of the feedback we used to get from different stakeholders, most especially beneficiaries, they are here. So we have a provider like from Winyangabo who gave us a response that when you ask, what has she benefited from this kind of training? And you can see someone saying that I think these trainings have helped us to improve our skills because these days there is improved quality of services we offer to our clients. We offer these services confidently, and now the clients have gained confidence in us. That is a very strong statement. Now the client has gained confidence in the provider. It means she will able as the community to come and access services without necessarily waiting for implementing partners outreach. And this is good news, which we need to really appreciate. So this is a provider from Bunyangabo district. Then we have a district official who really appreciate this kind of approach where I said Maristops should continue with monitoring of commodities because this is something that is becoming a problem. At one time, we had totally nothing in the region, West Nile. And Maristops came in to support in placing emergency order from JMS, which solved the challenge. And we need to continue having this kind of support. This is not because we are blaming that they are not supplying, because you know the supply chain sometimes can have challenge. And we have what we call, government has a partnership with JMS, where the district can be supported to make emergency orders. NMS is also sorting out itself to push commodities. So they really appreciate we have been part of this process to support districts to make emergency orders in case facilities have run out of stock when NMS has not yet supplied. And it is also part of our system strengthening. Then lastly, for Bunyangabo, we have a provider who says, Multistops came in, we would not know how much we would use the facility. But now, when they came in, they have now taught us how to do stock taking so that we can really know how much we need and what we are using so that we don't get stock out. This is very, very much important. During the transitioning of one facility, one warehouse, we have also supported facilities to train them in the transitioning to Electronic Logistic Management Information System and CSSP to ensure that the facilities are well trained to be able to understand how to forecast, quantify, and timely order for their commodities from the national warehouse, which is NMS. And we are part of the IPs that supported this transition, and you can hear feedback from facilities that they are now fully prepared. They know what to do other than providing services when they cannot really know what they need. And we have many that still continue to give us feedback regarding this and the kind of support we have provided. But in my presentation, at the end of the presentation, we have a provider whom we would like to hear from and tell us a story. What she feels, did she get any impact as a result of this kind of support? So we would like to hear from her at the end of this presentation as to add on what others have already said, to be able to appreciate the kind of work Multistops and partnership Multistops is doing with the Ministry of Health and the district leadership to ensure that we impact the community to address the challenges related to SRH services. So lastly, we have this slide which has learnings and recommendations because tomorrow you might be wanting to do the same kind of capacity building, but there are things you need to pay attention. One, you need to create ownership from the start. When you are doing health system strengthening, this is a very important thing. You may go thinking that you will go to the facility and do things, but you need to ensure that the ministry people own this issue. Because at the end of the day, whatever you do, you need to hand it over so that they're able to sustain it. So if you cannot create ownership from the start, it becomes very difficult to build a sustainable capacity. And this is the point we have crammed, and we have understood it very well, and we have seen a lot of gains from it when we are implementing system strengthening. Then second, we need to ensure that you jointly select facilities with Ministry of Health leadership. One, you may select these facilities and you end up going to wrong facilities that are already having people who have been trained, or the other IPs that are already in those facilities, where you end up overlapping in those facilities, and which duplicates support and also resource wasting. So ensure that you engage the district leadership to show you the facilities where you need to be, that have gaps that you need to address. Then the third is that ensure activities are aligned with the needs of government. It is very, very much important. Don't go thinking that the facilities don't have everything. No, there is already something already done. So your role is to ensure that you work with the ministry, work with the leadership at the district to do a needs assessment and go there to fill the gap. And that's where you will bring the component of value for money, other than going to train people who are already been trained, and at the end of the day you are duplicating support, duplicating services, and which does not bring a component of value for money, but also ownership. The moment you address where the gaps exist, that's when they can really appreciate your kind of support. Continuous support, supervision, and monitoring, which is jointly, is much important. You cannot train people and leave them there. You need to keep going on ground and ensure that the people you trained, you do a follow-up, assess them, and ensure that the services they provided, they meet the desired standard, and they also ensure that there is client safety in terms of quality of services they are providing. Then ensure that you support a wider system. as earlier stated, that when you are doing FP, don't only focus on FP. Because they provide their training in FP, she will need HIMS tools to document. She will need to understand how to document the services she has provided and report them. She also needs commodities and consumables. So you need to support a wider system to ensure that the gaps are identified, are addressed, and the facility is fully prepared and equipped to provide quality services. Yeah, that marks the end of my presentation. Thank you. So, Andrew, you request to call one of the beneficiaries to tell us a story.
In the interest of time, can I have that done a bit later because our chief guest has to run to Parliament. But let's appreciate Dr. Martin again in a special way. Thank you so much. Our provider, you are going to give us that testimonial because we need it to understand how critical all this is. I want to appreciate our development partners who are here and other partners, our implementing partners here with us. But because of time and our chief guest having other engagements, competing priorities, you're going to allow me to welcome the Director, Curative Services, Minister of Health, representing the Permanent Secretary, Dr. Diana Twine, to come and give us his speech, and thereafter we shall proceed. Let's welcome Dr. Charles Olaro.
Thank you, Director of Ceremonies. Our director, the Senior Country Director, Maristops Uganda, and your team, our donors, development partners, UNFPA, Netherlands government, FCDO, and members of Parliament. I found the Vice Chairman of the Health Committee, he had to leave because he had another meeting. The National Population Council, all our implementing councils, implementing partners who have been mentioned, the local governments represented here, the DHOs and the ADHOs. My colleagues from the Ministry of Health, the two Richards, Richard Mugai and Richard Kabanda. Good morning once again. It's my pleasure to be here. First, I bring apologies from the Permanent Secretary who could not be here this morning, and I willingly accepted the delegation to come. So I'm happy to be here. I want to first applaud Maristops for whatever they have been able to do in partnership with government. And as I've been sitting here, I've been doing a lot of reading. If you look at the annual report and you look at what they have been able to, the impact, who did we reach? And I think that reflects everything. So probably if I said just what you have indicated there, and then read the statement of the Permanent Secretary, then I could be able to go. But specifically, I want to highlight a few of them. And as you know that, if you look at, they did indicate they have been able to reach almost 1 million clients. And through the partnership which you just had Agaba speak of, they were able to reach 528,000 clients. That's through the public sector. And you know that the public sector should be able to be strengthened. All of you recall that there was a time almost when the public health facilities were not ordering what? Supplies, because they knew that the partners were going to do this. And over 79% of it has been delivered in underserved communities, because here we are looking at addressing equity, really leaving nobody behind, so that they are really focusing that in those areas where there are no people. When you look in terms of unintended pregnancies, they were able to avert 970,549. Richard, you know that if this had not happened just from Maristops alone, how many babies, because already we have about 1.5 million delivered every year, that would also have been added as the number of babies who would have been what? Who would have been born. But significantly, key among them is that they were able to avert 2,775 maternal deaths. So these are not mean achievements. So you just on this page alone, you can be able to see that there's quite a lot of, in terms of unsafe abortion, almost close to 500 million abortions were averted. And then if you look, for those who understand money now, you look at the bottom, you will look at that, it's about 55 million pounds. So this all would have been cost if they were not able to access these services. So allow me at this point to go through the speech of the Permanent Secretary, that Uganda's National Family, as definitely as part of Uganda's aspiration, is that the Uganda National Family Planning Advocacy Strategy, which we launched, which really guides us from 2021-2025, is anchored on and to seek to contribute to the vision and the goal of family planning costed plan. And the vision of the costed plan is universal access to family planning to help Uganda attain the middle income country. If we don't talk of family planning, we can't get people out of poverty. We can't get into the middle income countries. So, brackets. Though we have been told that we are at the gate, but then we might remain at the gate, and if we do not do one, be able to handle this. So we want to reduce the unmet need of family planning to less than 10%, and to increase the modern contraceptive prevalence to 46.6% of all women in union by 2025. However, all of you know that Uganda, the population is estimated about 47. I hope when we do the population census, we will be able to confirm this. And slightly more than 55% of them are less than 18 years, with a high dependency ratio of 69 people per one working adult. So you can see this asymmetry. So one working adult supports about 97 people. So the demographic profile could make or break the country's prospects for attaining Vision 2040. The maternal mortality ratio is still high. It remains at about 336 per 100,000 live births, according to the demographic survey of 2016. But based on our health facility, maternal mortality ratio is coming down at about 87%, 87 per 100,000 births. So, but we wait for the scientific method to be able to confirm that. So if you looked in that aspect, that translates to about 1,250 mothers who die what? Each year. And if we have not had family planning, then probably the number could even have been what? Could have been much more higher. According to the PMA, Performance Monitoring for Action, survey done in 2022 by Makerere University School of Public Health, it indicated that nearly half of most of the recent pregnancies within the 5 years were unintended. 34.9% of all women had had unintended pregnancy in the last 12 months preceding the survey were unintended. And this proportion, if you look at those from 15 to 19, was even much more higher at 62.9% as unintended pregnancies. So this has got a devastating toll on women and girls leading to nearly 700,000 unintended births each year. and some of them definitely unsafe abortions. So family planning is critical for safe motherhood. As you know, that's one of the key pillars of safe motherhood. So as we speak of vaccines for prevention of childhood illnesses, we also have to look at family planning as really a prevention, a vaccine for what? Prevention of all these poor outcomes which happen to mothers and children and women of this country. So even though contraceptive awareness is almost universal, with 99% knowing at least one contraceptive method and pregnancy prevention, 28% of the adolescents at the age, 28% of our adolescents between 15 and 19 have already started childbearing. And 28% of the married women have got unmet need. So the knowledge is there, but this now is issues of knowledge and the practice is really what comes in. Last week I was in Malawi, and there are quite many things which I saw, but one of it is definitely that if you look at those under 18 years who are able to access family planning, their numbers are much bigger than what? Ours. Ours who are still limited with the policies, we are looking at we are still at the value proposition than the rights what? Propositions. If only the modest investment in family planning and education are made along with aggressive economic and governance policies, you will be able to see that the Uganda GDP is projected to reach $6,084 United dollars by 2040, from 506 in 2011. However, when more ambitious family planning and education programs are prioritized together with economic and governance policies, then the demographic dividends even becomes bigger, to 3,500 per GDP. So I think we would need to be able to speak that investment in some of these things definitely translate to what? Money aspect of it. So we need to be able to do that. So I have shown you the contribution of Maristops Uganda. They are in over 700 facilities, over 95 districts. And I was speaking to Carol. I think we are remaining now with a few 50-something districts to cover the whole country. Our only limitation is resources. So because we need to be able to see that if we don't cover the other one, then it means still we're leaving some people behind. I'm sure there are many others in other districts which we could be able to reach with the same approach. So 95 districts, number of health workers who have been trained, best training and mentorship. This is part of the sustainability aspect of it. 1,235, and then in terms of post-abortion care, about 100 of them. So government is committed to implement the costed plan to target an increase in contraceptive prevalence rate for modern method to 46% and reduce the unmet need. And we have made progress in improvement of these indicators. So in collaboration with partners, definitely as a country, wouldn't achieve this without working with partners. We really want to applaud you. I won't be able to mention each by his name, but let's appreciate all our partners in this room. We acknowledge FCDO as is one of the major partners of government of Uganda, and we acknowledge the additional investment of £29 million over the 5 years to implement the RISE project in 7 regions of this country. But we are aware definitely that this is also due to end. And I was asking Carol that what is the follow-up? So it remains some questions which we'll do one. Because yes, we'll be able to achieve this, but we need to be able to do that. So as I conclude, I want to thank all the partners in the family planning space. If you saw those graphs, I was asking Carol again that looked like COVID even did not stop. What? It looked like there was no impact. And what that means that people needed the services. And she also did indicate that during COVID, we even worked much more harder. But I'm looking at it now in the absence of COVID, why could we even work much more harder? So we really need to be able to see that we maintain that trajectory and be able to do what? To achieve that. I have definitely two asks to the members in this room. One of them definitely is the aspect that if you look at our costed plan, definitely there are a number of things which we looked at, the high impact practices, which we think that we should be able to count. And one, I want to just single one of them, which we think that we can be able to make it differently, and it can change many of the things. And I'm looking at the aspect of postpartum and post-abortal family planning. Because if you do that, now that 80% of these mothers actually deliver in our health facilities, then we can be able to get them from there. And then probably get the others. Because if you don't do that, then either by the time you meet them again, they are not able to start family planning, they are already pregnant. So you would have lost. Or probably those who have had abortion, if not, then they have got again one. So I'm looking at it, is one of those areas which we need to be able to see how can we galvanize it. So Maristops, how can we be able to lead us in that area? The last area is definitely to be able to guide us in evidence, be able to projections, definitely we need evidence. So how can we digitalize? Again, when I visit Malawi, you see, even from the outreach, the data is captured directly from that point. And that data is transmitted to the health management information system. So you can be able to pull the data. So you don't need to get out of the outreach and then you go and start filling one. Yes, you can be able to do it, but you can be able to do what? So if we have addressed the aspect of digitalization, borrowing from what's happening in the HIV area, we can be able to see that how can we be able to strengthen family planning. With this many remarks, ladies and gentlemen, it's my pleasure on behalf of the Family Secretary to officially declare this partnership meeting, the second partnership meeting, open. Thank you, and thank you for your participation.
Ladies and gentlemen, let's appreciate the government of Uganda in a special way. And you're going to allow me to go against the intended agenda as planned earlier, that we can have the group photo in time. I'm going to request Dr. Olaro to kindly come back here to join. We have a group photo before you leave so that it goes in the archive for archive purposes, that you actually open this. Let me request our development partners for the British High Commission. Let's have Rebecca Bell to come and join us. UNFPA to equally come, that is Moses Walakida. Netherlands, let's have Ruth to come and join us. USA, let me request Tena Gibrat Sadiq to come and join us, and Patrick Komakech. Bagstum, let me request Comrade Dr. Francis Ndamaje to equally come and join for this group photo. The World Bank, let's have Brendan Hayes to come, as well as the Assistant Commissioner, Dr. Mugahi Richard, to join us, and OHT Wenyo, Dr. Richard Kabanda, Commissioner, Health Promotions, to come and join us for this group photo. You're going to come up here. Dr. Larry you'll be the leader. We are taking this photo for purposes of saving time later. Okay, that is well balanced. And the executive team, all of you kindly join the executive team from Maristops, kindly join in. The executive team. Okay, perfect. A lady in the middle. Anyone else? That's it? Okay, let's all smile to the cameras. Let's smile, comrades. Dr. Mugahi, let's smile. Thank you, ladies and gentlemen. Let's appreciate them. Ladies and gentlemen, now that that is out of the way, you'll bear with us as and when our chief guest will leave us, given the competing priorities. But we're going to continue with our program. And in a special way, allow me to recognize a couple of other eminent partners who are working with Maristops. We've been joined by Dr. Richard Kabanda, the Commissioner of Public Health Promotions, is here with us. We have from Sehad, Uganda, we have the ED, Fatia Chiaga, is here with us as well. Let's clap for them, comrades. These are good partners. National Population Council, we have Dr. Betty Chadondo. She's equally here with us. Madame Demographic Dividend. Other key partners, we have the Uganda Private Midwives Association. They are here with us. We have Naguru Teenage Center. Let's clap for Naguru Teenage Center. We have IRCU is here with us. Let's appreciate them. We have Stanbic Bank. Let's appreciate Stanbic Bank. And last but not least, we have BDO, that is the auditor. It's an external auditor, but they're part of us today. Let's appreciate them as well. Going forward, ladies and gentlemen, we're going to listen to the key note address that is coming in from Dr. Bonnie Wandera, who happens to be from the USAID Strategic Information and Technical Support Project. He's going now to give us the keynote address. Let's welcome him, ladies and gentlemen.
Thank you. Good morning, everyone. Thank you very much, Andrew, and you're welcome. I either have to be louder or... Anyway, I'm waiting for my presentation to get loaded, but could I have some volume, please? Thank you very much. I'm waiting for my presentation, but as it comes on, I was contacted by Maristops and wasn't given any data. What does that mean? I'm supposed to come here, talk about partnership with data from the government of Uganda. And I thought, wait a minute, my work is already done. That's partnership, meaning that they are sure that part of what they've done to support the government of Uganda, that data is available in the archives of the health management information systems. So what I did, yes, I think we need to upload that. Yes. Implicit in that is I am declaring my age and commending where we have come from. We know that HMIS forms used to be sent by bus to the resource center then and all that stuff. But here we are accessing them from wherever we are. The reason I am recounting that is we should visualize where we want to go. The director has given us an idea of where we want to go to be able to capture data in real time at service delivery points and to be able to modify our programs, identify which areas are in greatest need in real time. So I am recounting that just to raise our hopes, to open our imagination of what is feasible and what we should be doing. When I prepared a few slides to show you what Maristops, a couple of partners, very many have done to show how they're supporting the public sector. Partnership is good, but if there's anything I forget to recommend, it has to be something about accountability. The director talked about learning from the HIV program. How do we account? I know some of us are working 6 partners in one sub-county, and we have other sub-counties that have no partners. How do we say that this contribution is from this partner in this sub-county in this district? Part of that is using data, but part of that is working with the government of Uganda to see how do we reposition ourselves, how do we reach out to areas that are not having us enough support. So when we go to the first slide, who has the slides? I want to look at them so that they can flip with me. Oh, Andrew, did you hand me the clicker? Can we get the clicker? Yes, thank you. Okay, thank you very much. I'm going to use largely the HMIS data, and I use those processes for the issue of time. I know we are believers. You're going to believe that I use the right processes, and I'll make some recommendations at the end. Wow. And I selected a few areas that I will talk about: family planning uptake, method mix, teenage pregnancy rates, high impact practices, as the director has talked about, and also make some recommendations. So this slide really, if I am to say anything, is kind of a reflection of what others have presented, and it's just showing us if you get it, then you should have gotten it. but anyway, what it is showing is that over the years as a country, the clients that we are seeing in the facilities with the efforts of all partners and the government of Uganda are paying off. These are visits. These are not unique individuals, they are visits. And we see a bump in the last 2 years, 2021 and 2022. In there I have small bars, the blue, the red, and the gray. Most importantly is the dark blue bars, which are for our priority age groups under 19 years. And those are also going up, which is very good. I present a pie chart there showing that the majority of these services are from public facilities, but we still have a significant proportion from private facilities. Maristops and other partners, USAID funded and a lot of others, have reached out to support PNFPs and PFPs. So I think as we celebrate this partnership, I will identify how do we need to tweak this support to improve those services. But all you have to know here is that the uptake is improving, and the number of clients, up to now 5 million client visits. There are issues of data quality I will highlight, but at least we have put the door, rather the foot into the door, and we need to be improving. This is showing us the service visits by health facility ownership. If you look in the middle, there is a chart there. One of the bars shows a big purple band, and that is from the region of Kampala, showing that it has the biggest contribution of private providers. Nonetheless, also the other regions, we see a different composition of private providers and all these are reporting into the national system. And the reason I am showing this is that as we support the public sector, we know certain clients get their services with private providers. Are we inviting private providers to the training, to the mentorships, because they are still serving Ugandans? So that's part of the reasons that I am showing this, but I want us to reflect on that. Part of my task was to identify those gaps. I know some of us tend to work with only public facilities, but this chart shows that we are supposed to be working with other facilities, not necessarily publicly owned facilities. I either have to move closer. I seem to be clicking a lot. But anyway, through partnerships, we see that a number of services. The other data that I was showing is not necessarily static facility data. It also includes outreaches. And in this chart here, over the last 3 years, all you have to see is that as a country, the number of outreaches we are conducting have increased. But importantly, it's only about 73% of the outreaches we have volunteered ourselves to conduct. It is good we are improving, but they are not sufficient. And I outlined there regional differences in the proportion of outreaches that regions are conducting, and highlight which districts seem to be doing better than the others. This is data for last year, 2022. The information here is, as you support particular districts, are you able to look at how they are performing and what challenges are in their outreaches and what you need to be doing? That's what's most important. But we see that inter-regional differences in outreaches. Wow. So really, this is to recap. I showed you that FP user visits have increased over time, but markedly in the last 2 years, and a 70% increment among the adolescents, 45%, that is over the last 6 years for the other age groups. And we saw increases in all regions, and we need to be pivoting our programming to make sure, based on the data and on the need, to ensure that our services are responsive to the younger age groups and first-time parents. And regarding our partnerships, I talked about how 80% of our visits occurred at health center 3s and below. That is very key. Some of us work with only hospitals and all that, but 80% of our clients go to health center 3s. So if we interrogate the data, which we are supposed to support in collection, we're able to identify how do we then pivot the support. If we're going to work in Yumbe, are we going to only work with Yumbe Hospital? Yet we know most of the clients are going to lower level facilities. I highlighted the regional differences, and also trying to emphasize the issue of reaching out to PFPs and PNFPs, not necessarily supporting public-owned facilities. And of course, the recommendations which have been mentioned earlier, and I will come ahead on the issue of high-impact practices and then outreaches and all those. And of course, this one I really, really want to emphasize. It appears to be getting aligned in the HIV sector, but for reproductive health is how IPs, how we are distributed. Some regions are dry, others are, we are congested in one district. So how do we align our services? How do we synergize? How do we leverage from each other so that if we want to work in 4 districts, then what we are doing is not the same as what partner X, partner Y is doing in that particular district. So anybody from UFPC, this is your role to be supporting us going forward. I know I am preaching to the converted, but when you look through the data, since we are all going to claim we support the government of Uganda, we should also be able to claim a proportion of that support in that data. So in the region, I think, my name is Wandera, but the tribe in central Uganda, they have that saying, amamesa amanji. Yes, so if you get it, that we should be able to align that. I think if there's anything, that's part of us as stakeholders in SRH to think through how do we align that. There is a regionalization in the HIV sector, and we should be thinking, how do we do it? We could continue working in the same districts, but how do we structure the support in a way that it's efficient, and then we are getting more out of that. So when I go to the next indicator on teenage pregnancy, this is health facility data. It's about 15%. The numerator is the number of girls attending antenatal care. Of course, that's influenced by attending antenatal care. We're seeing about nearly 400,000. That's the maximum on average per year in all the facilities in Uganda. A very slight fall if we use the numerator is the average number, rather the number of adolescent girls 15 to 19 years. So from about 15% to about 13%. But this varies by district. On the left there we see some districts seem to have a higher problem than the others. So as we are supporting and as we are designing adolescent responsive programming, which districts are we going to choose? Of course, it is very clear that the southwest region there is in lighter colors, not as bad, but we see the mid-north districts in Lao, Choli, and then in the west we see Bundibujo, and then around Hoima, and of course when we go to the east, so those pockets where teenage pregnancy is an issue. And when we go to the next slide, I seem to have missed. Okay. So when we, yes. So I'll continue pointing up. So really this is what I reflected on and how we should be working beyond family planning as a program to address the other issues that are important, and how we are leveraging existing programs, the DREAMS program, other community models to reach more adolescents, and working with other CBOs and CSOs is what we should be doing. But as well as knowing that if we have a national program, we should be following the data where teenage pregnancy is the highest. Of course, it's a few years after the lockdown. There's no way I cannot show this slide, how everywhere on the radio and TV we are talking about lockdowns and teenage pregnancy, and how all teenagers were getting pregnant, for lack of a better word. I know I see very many people from data, and we have interrogated data over the years, and honestly speaking, there was an increase in the number of teenagers getting pregnant. But if I'm to use language where you can quote me well, we were just eroding some of the gains we had achieved. The numbers were not way beyond what we've never ever registered. We are still within the ranges we had registered. The only thing is that instead of going like this, we kind of just bumped a bit. So I am showing that I just want us to be aware that, yes, at that time, there were a lot of challenges, but we should continue doing what we were doing. And I'm emphasizing the issue of data. The director talked about how initially everyone was talking about how people are not accessing services. The data shows otherwise. How everyone was getting pregnant. This one is not very clear there, but it shows about, it says that, this is on some website, a total of 354,000 teenage pregnancies have been registered in Uganda because of lockdowns. But I've showed you previously about 400,000. So we should be aware, we should be able to robustly defend our data and not let people tell our stories. I'm not saying we should deny, but we should acknowledge and be able to respond with data and be able to appropriately design our programs. Talking about abortion, the director talked about how it is very important. We're seeing about 70 to 7,400,000 clients coming for post-abortion care in facilities that are reporting in the HMIS. That is a big number that we should be providing post-abortion family planning services and counseling if they need them. So all I am emphasizing that number is very high, and regarding whether we are providing them with post-abortion family planning, this map is showing that yes, we are. In some districts, up to 50% of the clients who come with for PSC receive post-abortion family planning, but in the others not. We see a lot of gaps in Karamoja, a lot of gaps in the Midwest, and also in the Southwest. So depending on where you come from, we see that generally post-abortion family planning, we are doing very badly. That only 12 districts registered 50% or more of their clients as receiving post-abortion family planning, and this is 2021-22 Uganda financial year data. And we see 38 districts or cities had less than 10% of these clients who have come for a service, and they did not receive post-abortion family planning or counseling. And of course, I outlined differences. I know they will share the slides, but if there is anything, all I am trying to emphasize, and I believe why Maristops reached out to me, was to just to remind us that to interrogate our data, which we have access to, which we have supported the government of Uganda to collect. And the government of Uganda has graciously given us access. So when we're designing our programs, we should be looking, if I'm supporting the Eastern region, I shouldn't be doing blanket programming. I should be identifying which of my geographical areas of support have the biggest gaps. Here I outlined the differences. We see that we appear to be thinking or providing post-abortion FP to younger girls in this on the first quadrant here. 28% for girls 19 and below, but slightly less for older women. The data is only in two categories, below 20 and 20 and above. 22% in above 20 and 28% in below 20 years, which gives us an average of about 24%. So of every 4 women who walk into our facilities, only 1 lives with a method. I am not saying 100% should live with a method. I am going to presume we have provided training, we know human rights-based approach, we know counseling and everything. So that will depend on the client, but there are also a lot of other considerations. And we know that fertility returns soon after abortion, sometimes up to 20 days, fertility has returned. But 1 in 4 is really, really very low, and this is a low-hanging fruit, and I've shown very high numbers of clients that are coming for a service. And we see it appears private for-profit facilities are doing this better than public facilities. So if we are supporting public facilities, it's an issue of commodity availability and the other issues. So this is some of the issues we should be interrogating as we support and identifying what is causing these differences and why is that so. And we see health facility variation. See, lower facilities, 37% of their clients receive the post-abortion method, and this goes slightly lower, but the national referral, very good, probably because it has consultants, but still they see very few people. So the most important thing where I mentioned where most of our clients are, we should be concentrating where 80% of our clients are, the lower level facilities, and we should be supporting them very well. So these really are the reflections that I've talked about. I think I shouldn't be going through I think leadership and how we organize our services to be able to provide post-abortion family planning and service delivery guidelines and protocols and a lot of other reflections, really. So the other high impact practice that is available in the data is on postpartum family planning uptake, and it shows over the last 3 years, we are moving from red to some green, good, which is good. There are challenges with the data that we are collecting, and we are trying to improve that as we go along. But there is a positive change, which is good. what we need to be thinking about as we provide that change is the timing. How early are we providing this? If we know postpartum family planning, information and counseling should begin way earlier, not necessarily at in the PNC clinic. So when we go on the first pie chart on the left, we see that the majority are receiving a method after 6 weeks. And to some, fertility has returned, some might have other challenges, and we know the frequency of accessing health services at that time reduces. So the essence of drawing that pie chart was to remind us how we are aligning our services in ensuring that we provide postpartum family planning earlier than 6 weeks, of course based on the client and a lot of other assessments that are done by providers. And the other is another issue to consider is the method we are providing. We know that as family planning in general, most of our women and men are using short-term methods. And we also see it here in postpartum family planning. Short-term methods are predominating. That black are injectables, 54%. If it is client's choice, well and good it is, but how are we removing provider bias? How are we ensuring commodities are available? And is the provider confident to provide immediate postpartum family planning? Is the commodity available? Do we have the other logistics required to provide a postpartum IUD? So all those are the issues we should be talking about and supporting the public facilities as well as the private facilities to ensure that we are providing postpartum family planning. And I can't forget the issue of the data capture and reporting. All the methods we've provided in maternity, fortunately the DHI and with all your inputs has modified all the reporting tools to be able to capture all this, and so we should be supporting facilities to adequately report that. During the exhibition, somebody was asking about how we are ensuring that mothers who are coming for services, for immunization, for other services in the OPD are not missing out on receiving information on postpartum family planning. And what this very busy chart is showing is that some of although we are seeing more mothers coming with children receiving other services, those numbers are not necessarily equal to those that are receiving postpartum family planning method. I am not saying they should be equal. There are a lot of other intricacies. The reason for showing this is to show opportunities for providing postpartum family planning early. Then also how we structure our PNC clinics and young child clinics to ensure that the way they are structured, the client flow and availability of methods is in a way that makes it easier for mothers not to miss getting information and a method based on their discussion with their provider. This slide is one where I really very little to say, just to show that based on what as a country have set in our MOH strategy, we want to be able to get about those CYPs. I think it's about 4 point something, and we are achieving those. But there are a lot of other gaps that I have mentioned. So over time, we see that the number of CYPs as a country, which is blue, the red one is the target. We are achieving that. But I will show you other perspectives that are also important to consider. Of course, we know CYP has a lot of other things that come into play, the method given and all that. So one other important component is after providing information, comes in the method that we have at the facility. This is how the data that is in the national system looks like. 33% of clients receive condoms. Do you want to believe it? let me, by show of hands, I know I have no time, but there was a student teacher who had their supervisor come in, and they told the people that I want to pass this internship. I'm going to ask questions. If you are sure of the answer, put up your right hand. If you're not sure, put up your left hand. That said, do we believe 33% of our facilities provide condoms to clients? I want the right and left hands so that I choose the right one. I want to pass. Anyway, the point I'm trying to say is this is the data we are supporting facilities to provide. If we looked at survey data, I see Simon, I know there are people from U-Boats and all. It's definitely on the upper side. If we look at survey data, this is not 33% of our population are really receiving condoms. So, yes. Really? Yeah? No, 30, as one of every 3 people that we see is taking condoms home, which is not. So I'm just emphasizing the issue of quality and how we're supporting the facilities. That said, if we ignore the condoms for now, the other methods, we see that over time, if you look at the black broken line, the number of clients that are receiving DMPA-IM is reducing as those receiving DMPA subcut is going up, which is very good. And we see we are doing very well in increased uptake of implants. I know all of you were in the PMA dissemination, which was virtual, and that is also reflected in that data. So this is the contraceptive method mix by region. What is important here is some regions have 3 or 4 bars only. What is important is the facility, the region, the district you're supporting should be having many bars, or it can have 1 bar if it is client choice. The issue is how are we ensuring that we are ordering the methods that need to be available for the clients. And I see Kampala is a bit balanced, and as we move further, we see Karamoja has a very big gray bar, 39%, and the gray, this screen is not as nice, the gray here are fertility awareness methods, 40% FY22 in Karamoja. If it's client choice, excellent. If it is any other issue based on really non-availability of other methods, that is where our gap is. So the essence of showing this is that we should be interrogating the data for the facilities we support to ensure that all the methods are available and the clients receive them, and the health worker know how to provide them. I know in the FPCIP2, the country pledged to ensure that 100% of the health center 3s and above provide implants. I put it to you that the biggest proportion of our clients get services from health center 3s. Since we want them to provide health implants, or to be able to provide, in the data I interrogated and saw that the proportion of facilities providing implants is increasing over time at about 76% of health center 3s. But there are some inter-district variations, and largely the district, the other rim in the northeast seem to be doing not as well as other pockets. And since we do not work at the district, service delivery occurs at the facility, so we should be drilling down the sub-counties you support and ensure that this facility is equipped, has trained workers, orders, and has in stock implants. And here is just an outline of a few districts. In the west, we see Kagadi. When you drill down and deep dive, you'll find that some facilities did not have any dispense any implants in the last 12 months of 2022. And the issue, some of them by their names, and by discussing with the DHO, you'll definitely find that they are PNFPs. from a particular sector that does not provide some of those methods. But as partners, how are we engaging with those facilities to ensure appropriate referrals are conducted during the counseling? The information is as comprehensive. And then how are we inviting those facilities as well as others for training, mentorships, and all that? So those are the issues as partners we should be doing to really support a comprehensive FP programming. And that's why I'm showing some of these. The other map had some green. This one is for IUDs. If there's anything, all you have to know is that very few facilities are dispensing IUDs. This is FY 2020, rather this is 2022, and the red is at 50%. So most of the health center 3s did not dispense IUDs. I think in one of the TWGs, there was a presentation of why this is low and all that. But as we go back to work, we should be interrogating why and all that. So what I'm showing here is that IUD dispensing, health center 3s, very low. Over the years, very little improvement across all districts. If there is anything we have to discuss, I think it should be this. And I know I saw in the Q&A there is an issue about commodities. This is average availability of DMPA as a tracer commodity in the HMIS, suboptimal. Whether however much you slice it, there is work to be done. There has been engagements, repeated engagements, but how we actualize that and ensure that, yes, as a tracer commodity as well as generally all other commodities are available at the facility is an issue. It's not only for RH commodities, it is cross-cutting, but how are we adding on our pressure to the central warehouses to ensure that these recurrent cries come to an end? I think this is all I have to say about stock. So it's there and it's going down. Yes. And this is really the order fill rates, and some of them are below 50, and they have given some reasons, but we have to continue engaging. Fortunately, we have the commissioner here. There's been engagements, but the engagements have to continue. And for clients, I think we should be receiving results. When and how, that is the pressure, and that we need to continue applying. The other thing I think we should be considering is that the services we're providing, they should be more value than just coming for a method and then go home, more information. So how are we ensuring that, what was that tax? Over the top. So do we have over the top services apart from just family planning? So this is how we are performing, trying to screen for STIs, very low, less than 1 in 5. And then cancer cervix screening, very low. Of course, there's an issue there from the programming perspective, but are we do health workers know that this is part of the whole compendium of services to be provided? Is the room situated in a way that you're able to put the client in a lithotomy position, do screening and all that? So those are the things, as we support the public sector, we should be looking at. But what it was showing is that our over-the-top services are not as good. Yet, technically, if somebody was coming for FP information and a service, and they're receiving other added-on services, probably we'll be getting more clients coming in. So those are some of the things we should be thinking about. So where are we as a country? This is not HMIS data. This is where we are as a country. If there is anything you need to remember is that, yes, fertility is falling, but we haven't reached the target. Our target is about 5. No, our target is 4.4, I think, in the NDP3. And we're still at about 5 if we look at the MIS data, 2018-2019. But if we look at the UDHS data, we're still at 5.4. So we know every effort we're talking about should be coming into fertility. But some of the near-term indicators, which is MCPR for all women, we are at 34.9. the FPCIP, you as a country pledged to be at about 39.6. I used all women, and I like all women. I know sometimes we quote married women and all that, but I'm trying to, because it's inclusive and everything. So don't get confused with the numbers. The director quoted the one for all women. I'm just trying to keep the thought process continuing. So we still have that gap we need to cover. The unmet need, we want to be below 10%. We're still at 15. So how do we move that gap? And as we are identifying areas to support, there's a gold mine of data from different sources. So I know some of us are not aware of the fertility rates of the districts we are supporting, because we read the UDHS summary and stop there. But when you go and dig deeper, there's even fertility rates for the districts, and then you're able to know where they are and where they will be. The census is coming soon, so we should be able to get that. So how we do that is important, and our programs should be able to have that and help us in choosing. And this is data from some additional surveys that are done around identifying inter-district variations in contraceptive prevalence. We know the PMA is supporting us, giving us really a general overview of MCPR and a lot of other indicators, but we also have access to some data. And as partners, the other time I pointed at UFPC, if we're able to know that one partner has some funding for a survey, this partner should be having funding for this and this. We pull these resources together and be able to move. But this is not something we are doing very, very well. The HIV sector is doing that very well in some. Of course, there's a lot of external funding, but it's aligned in the way that they are waiting for the UFIA, and they know how to use it. But some partners have this data and others are not aware. For them, they're able to know that in the region, I see Apache and Kwania has a higher demand for modern contraceptives certified than the others, and they pivot their programming using that information, which is a call that I've kept repeating in different perspectives, and we should be aligning our support in that way. So the point I'm trying to emphasize here is that our programming has shown gaps in the different areas I've highlighted, and we should be looking out from the other players in the subsector and seeing how we align our programming based on the data and those gaps that I've identified. I give a lot of reflections, but I know they will come up in many areas. I'm cognizant of the time, but the issue of yes, I'm looking at Andrew, so I'll give him the back side, and then I remind you how we should be looking at really a multi-sectoral approach for family planning. And I see Dr. Chadondo, and really we should be drilling down and talking about FP as a development issue, and how are we supporting really the multi-sectoral approaches. Fortunately, the government of Uganda that we want to support is also now looking at program-based planning. We're no longer looking at the sector per se. So also our support should be supporting the program, not necessarily the sector. How are we building? Because in the end, the last mile, we are delivering services in a parish. How are our services embedded into the PDM, and how are we building onto the data capture in the PDM and all that? So those are some things we should be thinking at implementation level, and how we're able to support and look at family planning that way from the PDM perspective. And of course, issues related to advocacy and funding and equity, and there are also other innovations on the support to G2G. The government has aligned the regional referral hospital strategy. We should be working through that, working with the regional referral hospital to improve technical capacity of the facilities within that region. In that way, we are going to support sustainability in a way. And of course, data, are we drilling down? The HIV program has burden tables and all that. Do we have our need tables that drill down? This is our demand, this is our need for this sub-county. In that way, we're able to be very precise in our programming. And of course, they talked about looking at the health system in general rather than a particular program, and looking at what we have identified in the CIP as important high-impact practices. We're implementing CQIs and all that. And of course, rebudgeting demand creation. I will talk about that later. And a lot of other pivots that we've talked about in trying to improve service delivery. Really, these are rewarding of the gaps that I talked about when I was presenting the data, so I might not need to go through them. And this one is very full, and I know Dr. Walakira will talk about what we need to be doing about the supply chain. Very many issues. The government of Uganda has been gracious. We've seen that letter from the PS, NMS acknowledging and all that. Excellent. We should be clapping for that. I think the government really committed. No, that is very good. In the last TWG, there was an issue about the committed funds and all that, yes, but I think a big cognizant of where we are coming from to there, we should be hopeful where we should be going. Of course, we have a 10-year supply chain roadmap and how we're working with the government to ensure that we actualize that. And a lot of other issues. The division is working to align the ADS strategy and all that. There are a lot of other innovations that are going on, but how to fast track them is an important issue that we should be remembering. And of course, I should have talked only about data, but if we're able to drill down, as partners, we should be pulling resources to improve our reproductive health and family planning data, from collection to documentation to recording to use. We should be able to be thinking about how do we pull resources together to conduct our own inter-UDHS surveys along the way. PMA is externally funded. How do we come in to see that we're able to contribute to a basket fund where we do that? I started with the other one. I know all of us never expected that we'll be here where we just go with DHI access and then we get access to data. I want us to also be positive that it's possible that we can pull our resources together to be able to conduct our own RH-related surveys that are very informative for our programming. Of course, there are a lot of other issues related to research. And this one is showing a part of the work UFPC was doing, trying to align where partners are. How do we align services? Stop duplication. How do we work with the DHO to help us align and be able to leverage on each other's strength rather than doing the same thing for partners in one sub-count and the others don't have. So those are the things we should be doing going forward. Oh, I think I must have missed something. But anyway, even though I missed it, there's something I see Dr. Kabanda here. There's something about, it has to do something on, it's not necessarily related to him, but it's faintly related. It's about how we listen to the people we serve. What do they want? There is, I did not, the clicker disturbed me. I must have missed the Chinese pill. I had some photos of the Chinese pill, those who have heard about it. When you think about it, some of the reasons our clients tell us they're not using FP is side effects. The reason most of us know about the Chinese pill is side effects. The people are running stealthily to get it. So the point I'm trying to drive at is that the Chinese pill is identifying and filling a particular gap of what the users would want. They want a method which they take stealthily, one tablet, it's not injectable, to take them 3 months or so. So what does that mean to us? What it means is, yes, there is a need for methods, but it's possible that the methods we have people have identified particular challenges and they have questions which we are not addressing. Based on my discussions, getting that Chinese pill, it's not sold to you openly. They have to ask you who sent you. So people need it, people need a service, and they are working behind the back to get the service. So how are we positioned to ask the clients what they need? How do we provide them appropriate, timely information? Right now on social media, there is a hashtag Uganda Health Exhibition. How are we positioned to provide appropriate information for that particular segments of the population require, and how do we respond to that? So I think, for lack of a better word, I'm going to stop there, and thank you very much, Andrew. I really...
Let's appreciate him. You did such a great work. We'll have questions for him. I know when we're having a data kind of conversation, to those of you who are not used to these kind of conversations, you feel a little bored. So I'm going to request that we all stand up. Let's all stand up. Let's just all stand up. All of us, let's stand up. Make sure that you have enough space where you are. Make sure that you have enough space. Let's all stand up. Just stretch a bit, stretch a bit. DJ, let me have my song. Let me have my song, let me have my song. You raise that up. Just raise your left hand, rather your right hand. Right hand, right hand, right hand, right hand. Where you are, your right hand. Your right hand. Your right hand. Now tap your right neighbor. Just tap your right neighbor. Just tap your right neighbor. Tap your right neighbor. Tap your right neighbor. Tap your right neighbor. That's it. Just tap. Look for the right neighbor and tap your right neighbor. Tap your right neighbor. Tap your right neighbor. Dr. Kabanda, move to your right neighbor and tap your right neighbor. Tap your right. You move. Move to your right neighbor and tap your right neighbor. That's it. All right, let's go to the left hand. Let's go to the left hand. Raise your left hand. Raise your left hand. Tap your left neighbor. Tap your neighbor on your left. Tap your neighbor on your left. All right, now you can give your neighbor a high five. Just give your neighbor a high five for me. Just do that for me. We can take a seat again, ladies and gentlemen. That's how we're going to be working out in one way or the other. Friends, I understand the time is not on our side, but we're doing all that we can to make sense of the journey and the roadmap where Maristops has started for the last 30 years to where we are today. In a special way, among us here we have the DHOs, the district representatives, and when I mention them, please bear with me and clap for them because they do a very incredible work. We have the DHOs and the assistant DHOs. We have Dr. Sentamu Daniel, that is the DHO of Kalungu, is here with us. We have Dr. Mulwani Elisa, the DHO of Budaka, is here with us. We have Dr. Okwajiwath Justine, DHO Nebi. She's here with us. He's here with us, yes. We have Dr. Ogwal Daniel, the DHO Serere. He's here with us as well. We have Dr. Obeti Richard, DHO Bunyangabo. He's here with us. Good to see you, sir. We have Dr. Onik Okui, DHO Amuria District. We have Dr. Mulekwa Godfrey, DHO Palisa. The DHO from Palisa is here with us as well. We have the assistant DHOs, Dr. Moses Liagoba, Kamuli District. He's here with us. Thank you so much for coming. We have Dr. Nakantu Sara, Wakiso District. She's here with us. Thank you so much for coming. Businje Umve from Kayunga. This is the assistant DHO. She's here with us. We have Bira Joy from Kasese. This is the assistant DHO. She's here with us. Thank you so much for coming. We have Dr. Nakato Margaret Kalungu, assistant DHO. She's here with us as well. And we have Susan Trinomjuni from Nebi District, the assistant DHO. Let's appreciate them. They are here with us. Without any further ado, ladies and gentlemen, at this time we should have Miss Rebecca Bell, the team lead, humanitarian and human development team from the British High Commission and senior responsible owner of the RISE program, to come and talk to us briefly before we head to our panel. Let's welcome her.
Thank you very much. So, Ministry of Health officials, Country Director for Mary Stopes and members of the team, members of Parliament, district health officials present, and different partners in attendance. All protocols observed. So, as mentioned, my name's Rebecca. I'm the Humanitarian and Human Development Team Leader at the British High Commission and the Senior Responsible Owner for the RISE programme. So thank you for having me here today, and thank you for the excellent and informative presentation we've just received. To start, I want to commend the Ministry of Health for their commitment to address family planning gaps, particularly your allocation of 5 billion Ugandan shillings for procurement of family planning commodities this financial year. I also want to commend implementing partners and district officials for working to improve and deliver access to reproductive health services. And I want to recognise other development partners present, all of you, for your dedication to improving the lives of women and girls through enabling access to a wide range of reproductive health products and services. And importantly, it's their partnership day after all. I want to thank and take a moment to reflect upon the work of Mary Stopes. As you're aware, in 2021 to 2022, Uganda reduced the unmet need for family planning, and Mary Stopes has been a big part of that. The figures and details in the annual review, which the director, Dr. Olaro, mentioned earlier, show the important work Mary Stopes contributes to. So my task today is to speak about the role of the UK in supporting initiatives that promote reproductive health and our commitment to strengthening the public health sector in Uganda. So firstly, I'd like to reaffirm the UK's commitment to reproductive health. We want to provide women and girls with the freedom they need to succeed, because when women and girls prosper, the country prospers. So the 8th of March this year, the UK launched its Women and Girls strategy, which focused on 3 pillars. The first, educating girls; the second, empowering them; and the third, ending violence against women. Prior to that, and in December 2021, the UK launched its Ending Preventable Deaths position paper, which talks about how the UK intends to contribute to ending preventable deaths of mothers, babies, and children worldwide by 2030. So it's on this basis that the UK is an active partner with the government of Uganda to empower women through better sexual reproductive health, a critical issue for any country to address. So in the interest of time, I only provide a high-level view of the UK's commitment to strengthening the public sector in Uganda. So in the last 5 years, the UK has invested over 40 million through 2 sexual and reproductive health programs. So one of them is RISE, which you've heard me talk about and others talk about already, and the second is WISH. The combined efforts of these 2 programs is strengthening of over 400 public sector health facilities to independently provide reproductive health services to Uganda's population. The UK continues to contribute to the UNFPA Reproductive Health Supplies Programme, which ensures uninterrupted access to reproductive health commodities. We remain the largest donor to the UNFPA's Health Supplies Programme since 2014. And in addition to these, through our contribution to the ERMCHIP programme, the UK has committed to health facility infrastructural improvements, recruitment, and payment of human resources for health aimed at improving reproductive health and reducing maternal deaths. So as you can see, the UK has invested supporting efforts towards strengthening the public health sector in Uganda, and our commitment continues. We look forward to continuing the partnership with Mary Stopes in Uganda and elsewhere, and we're also delighted to continue working in partnership with others here today, including the Ministry of Health, to safeguard the gains made in advancing women and girls' reproductive health in Uganda and building upon those. Thank you for your kind attention.
I really want to appreciate Rebecca for being very kind in the interest of time. Ladies and gentlemen, we are going for a panel discussion, which is going to be very much curated to the agenda we are having today, but notwithstanding that it's going to be timely. And I want to appreciate those who are tweeting. If you're tweeting from this room, The hashtag is quite very simple. The hashtag is MSUG Partnership Day. Please just make the MSUG in capital and the P and the D for the day. We're going to have a panel discussion, and on this panel discussion, I'm going to request these eminent participants to join us up here. Let's have Dr. Richard Mugahi, the Assistant Commissioner of Reproductive and Infant Health, to join us up here. Let's clap for him as he makes his way. Dr. Moses Walakira, Programs Coordinator and SRH Integration, UNFPA, please kindly join us up here. Dr. Obet Richard, District Health Officer, Bunyangabo, kindly join us up here. Let's have Ms. Fatia Chiange, the Executive Director, SEHAD, to join us up here. And online, we shall be joined by Ms. Amanda Joan Banura from the Uganda Youth Focal Point, FP 2030. And then, as they take up their seats, let me request to have a 5-minute video to play to give us the context of the conversation. Thank you.
Access to contraception means a lot to women and girls in Uganda because Uganda is one of the countries that's still struggling with a high maternal mortality ratio. The penetration of the public sector to go out and in the very rural communities to meet the very last person is minimal. So that affects access so much. The partnership is really one of those very strong partnerships. MSI also works with our healthcare workers in the government, the mainstream public sector, and supports them in building their capacity, especially for the long-term family planning methods. They help the public sector to bridge the gap. They go where the access to contraception from the public sector is minimal.
Our approach is to partner with the local governments and get them to understand, first of all, the importance of family planning and how it will help in delivering a better maternity health care package for their constituents. And once we have the local government on board, then the district health team is part of that, and then we get introduced into the communities.
Work together as a team. Basically, it has taken us through community advocacy, through community dialogues, through community sensitization. Also done some mentorships and coaching at facility level, especially at lower centers, in those facilities which are not reached. So we shall have what we call performance review meeting. Each facility presents its data and we identify gaps and work on them as a team.
I didn't have much confidence in offering long-term methods of family planning, but since we started partnering, they trained us, they trained me, I became confident, and I also started training my fellow service providers. Also, counseling was also very poor. Even the data quality was not good, but there was a great improvement.
Traditionally, the way our public health facilities are set up, they're not traditionally very inviting for young people. But when you do the work to build competence for health workers, to know how to talk to and address young people, then you make a difference. So during the time we have been working in public sector, we have seen the proportion of young people we are serving grow from 9% in 2018 now to 14% in 2022.
Habokuba nenyamba kugumizamu n'emisomo yange and they prepare for the good future.
I want to say that the future of the partnership between MSI and the government of Uganda or Ministry of Health is something that we need to nurture and support. We can work together and map out areas where we think our access is very minimal to go and bridge the gap.
Access to contraception is doing wonders for women in this country. Because we're building capacity within government-owned facilities, it means that even long after MSI has stepped out, ideally, these services should be able to continue. It's there today, it's there tomorrow. Every time women and girls walk into these facilities, they receive services by members of their communities, people that they trust. And that really does help with acceptance, it does help with busting stigma.
Ladies and gentlemen, let's clap for Marie Stops Uganda in a special way. Those are great strides, and with me, my panelists here, I have Dr. Richard Mugahi, I have Fatia from SEHAD, I have Dr. Walakira and Dr. Becht on the other side joining us for this conversation. Inclusion, no one should be left behind. That's why Fatia is seated right in the center to balance the boat. I'm aware of what happens online when such a picture goes and the lady is on the far right or the far left, how the conversation can switch. But we have it all balanced here, and those giving us feedback online, I'll sample a little bit of your feedback a little later. But let's start this conversation. Dr. Mugahi, we were listening to the data from a comrade, Benny, and it was a little bit disturbing for me. I want to understand what can be done to ensure that family planning services are integrated into broader reproductive health programs and services, and that they are supported by policies and programs that promote gender equality, but at the same time, enshrining the women's empowerment.
Thank you, our moderator, and dear participants. Just direct to the question on integration. We clearly at Ministry of Health level, that is policy and strategy, there is a clear framework on how we can integrate family planning in the broader health framework or service delivery system. That is not enough. Integration ideally should be able to exist at service delivery point. And I'm very excited that we have a number of managers, healthcare managers at service provision level. So the strategy and the policies emphasize integration of services, but when you look critically at that slide, there's a slide that captivated me, presented by Bonnie, where you see a discrepancy between family planning at 6 weeks and immunization. Clearly, that tells a big story that whereas you can have very good explicit policies that prescribe what should be done, then if you don't emphasize this at service delivery points, if you don't follow it up, if you don't build capabilities to deliver the integrated package, you still get the wrong result. So the measure of success is where Bonnie is. The measure of success should not be having a document at Ministry of Health or a document at the DHO's office that is saying family planning should be integrated. We want to see every mother who comes or interfaces with the healthcare system at 6 weeks postpartum being counseled or given family planning, being counseled about family planning, and they should actually be the same numbers. So when we talk about integration, All I can say is that progress has been made. The policy environment is conducive. It speaks the same word. But the policy practice disconnect is what we need to address as partners. And I'm excited that we are now talking about partnerships that can help us address some of the policy practice disconnects. And I think that is where we are leaving some people behind. And clearly, we've not gotten everyone on board. This morning, we had a maternal death review of a young girl, a 16-year-old adolescent from Serere. I heard the DHO of Serere is here. They probably know about her, who was probably denied family planning by a healthcare system who could not access. She went ahead, got a pregnancy, chased away from home, went to the grandmother and finally aborted, and came to hospital when it was too late with complications of abortion. So we are still leaving people behind because of the policy practice disconnect. Integration is not the issue. Thank you.
Thank you so much, Dr. Mgahi. He has a presentation where he's going to dig into depth that we can make sense of what he's saying. Fatia, we need to understand to what extent does the effectiveness of civil society organizations in advocating for adequate coverage of FP services at the decentralized level depend on the level of independency from the government and the sector?
Okay, thank you so much, Andrew. I think civil society, as we know, is operating at the national level, but most importantly, it's operating at the subnational level, and it's joining efforts with government. We've seen all through the morning that Marie Stopes is actually joining hands with government, and I think that's what we call the effectiveness of civil society in advocacy. We are seeing data coming through Marie Stopes. Data is an important tool for effective advocacy, and it's coming through civil society that is operating both at the national level and also at the subnational level. We also see that some civil society organizations are already established at the subnational level, even through MOUs with the district health offices and the district political offices. And that is already showing effectiveness and transparency in terms of how CSOs are prepared to deliver advocacy to increase family planning services. But we also know that some of them do have offices within the districts and within the communities. Some of them have established community-based structures. At SEHAD, for example, we have a structure called Community Health Advocates. They are highly empowered in terms of the human rights-based approach, so we do legal empowerment for them. Then they know the policies, they know the laws, but equally, we empower the healthcare workers on the same. Dr. Mgahi was saying the practice policy gap. We need to address that by empowering both the duty bearers, healthcare service providers, but also the CSOs, for them to be able to follow through accountability. And indeed, we have quite many of these CBOs operating at the subnational level, following through and asking for services and helping to drive and increase demand for family planning services. And I see that as all those as elements for effective CSO engagement in terms of family planning services.
Thank you so much, Fatia. Dr. Obeti, we want to look at how the DCIP program, how it can be adopted to meet the unique needs of the different communities. In this aspect, I want us to look at the strategies that can be used to ensure that the program is culturally appreciated and sensitive at the same time, because we understand how culture at times fights against the agenda of family planning and all, and the other strategies there. How do we make sure that they are culturally appreciated with the sensitivity they actually carry?
Yeah, thank you very much, Andrew. So this AP per se, it is something which has to be done at the local level. So we know we have national family planning costed implementation plan, but we also need to have district-specific costed implementation plan. So at this level of the district-specific implementation plans, This gives opportunity for the local teams, the local partners, the local leaders to look deeply into the context of the districts. So you need to do analysis of the gaps and of course the threats, opportunities within the district. And this will be able to enable the districts to come up with the strategies which are very specific to each society in those specific districts. Thank you.
Thank you so much. I love the preciseness. And the DHOs who are here, we always meet, and you guys carry quite a very big laden there. Dr. Walakira, how can we address the issues of stockouts and ensure a reliable supply of FP in resource-constrained settings?
Good morning, colleagues. Let me start from there.
Good afternoon.
It's an afternoon already. Thank you. He has asked a simple question, but also a very difficult one.
I wish you luck.
If I start talking about commodities, probably it is something, a discussion that can take us up to tomorrow.
Correct.
The aspect of commodities has different dimensions. And it's a whole spectrum, ranging from, let me start from the community. From the community itself, the intended beneficiaries for the family planning program, their ability to demand for the commodities or for the family planning service. So there are quite a number of factors. And then as you move up, for the providers themselves, the nearest providers to the beneficiaries are say the VHTs, because they educate, they counsel, they dispense the methods. But if they do that, are they able to appropriately document what they have dispensed? Then as you move to the facility level, there are quite a number of factors at the health facility level. The capacity of the providers themselves to quantify, to forecast what they need, to do the appropriate stock management of the commodities that they receive, to be able to place a right order to the appropriate warehouse. There are so many districts or health facilities where the ordering deadline is clearly communicated by the warehouse, but the facility will not place an order. Everyone knows, despite the reminders, they will not place an order. And then the good thing and the beauty, I think Dr. Bonewandela talked about it, we are transitioning from paper-based system to electronic systems, logistics management information systems. How many districts have been able to harness those systems just to be able to transmit the order to the warehouse, appropriate warehouse, whether it's a national medical store or joint medical store? Many of the districts have not been able to harness that. They have the hardware, the computers are there. For one reason or another, they are not using it. There may be electricity or no electricity, or if the electricity is not there, maybe the capacity to use the computer is not there. As you move up, let me quickly go to the national level. There are so many factors at the national level. The warehouse level itself, and I'm going to use the latest example. You've seen the discussions between the Ministry of Health, the Parliament of Uganda, the Ministry of Finance, over issues of last mile delivery. We very well know, this is known to us, that National Medical Stores, which is the main warehouse that delivers commodities to the public health facilities, takes commodities to the health facilities every 2 months. That means in a year, 12 months, a financial year of 12 months, they're expected to deliver 6 cycles. By February, they had delivered 1 to 2 cycles across the districts in the country. 1 to 2 out of expected 3 or 4. Automatically, there were issues which we know. A lot of them, Minister of Finance was not timely releasing the funds to NMS, so they were not able to do the deliveries, the last mile delivery. That one alone created troubles. I started from the perspective of the gaps, such that we know that when we work to close those gaps, then we know what it should be done. And what I'm trying to communicate is that the solution is not at the national level only. The solution is not at the implementing partner only. The solution is not at the development partner only. It's at different levels. of the healthcare system. All of us have a role to play, and a very big one. And if we appreciate that, then we can work, we can harness everyone's advantage and everyone's effort. And if we do that, and we appropriately tailor the interventions to the level and the gaps that exist, then we should be able to address the issues of stockouts. Thank you.
Let's appreciate Mr. Walakide on that. Now, we have a couple of presentations just to make us understand the context to which these conversations are. We're going to start with Fatia here, looking at civil society at the decentralized level, having the capacity to advocate for adequate coverage of FP services. So, Fatia, over to you that you take us through this.
Thank you, Andrew. Is somebody going to give me the... Okay, so my task is to answer this particular question. Does civil society at decentralized level have the capacity to advocate for adequate coverage of family planning services? I think right away it's a yes and no. Yes, because as you can see in that photo, those are CBOs who have been capacitated to be able to advocate for sexual reproductive health services in their districts, of course, including family planning. So in which case, indeed, civil society can have a role at that level. And some of the areas within which we have seen CSO operations have already talked to this particular slides, but I want to go to this next one is, civil society is involved in all these interventions here. Of course, we have seen how Maristops is involved in service delivery, but also they are using that experience to actually do advocacy, not just here at the national level, but also at the district level, at the decentralized level. And I think we need to promote that. The best advocate for sexual reproductive health and indeed family planning would be that person who actually provides the services. And indeed, the CSOs have a role to play in capacitating the healthcare providers in advocacy. It does, moving them from the service provision into the advocacy arena provides us with a lot of evidence to improve the services and also to improve coverage. So of course, CSOs are very concerned with coverage and quality of the services. They are taking a part in expanding the services. We've seen how Maristops has gone to more than 95 districts. Awareness creation, we've seen many CSOs, even at the district level, involved in awareness creation. They're involved in community empowerment, capacitation, engagements, and ensuring that there is meaningful participation of communities in FP services, referrals to some extent, but most importantly, CSOs are driving social accountability. You've got CSOs who are capacitated in the districts that are asking about the commodities. They are going to the facilities. They are also empowering the HUMICs, the health management committees. SEHAD, we actually know that the HUMICs have a legal responsibility and they have a lot of power to monitor services, the effectiveness of services, coverage, quality at the district level, but they are not empowered in terms of their powers, their legal roles. So capacitating CSOs, some of us have taken up that role of capacitating the government structures and the government groups to be able to take up their rightful role, especially in the area of social accountability. Then, of course, there are lots of myths and misconceptions around family planning because of the cultural and social and religious norms, and CSOs are doing a lot of messaging and addressing these myths and misconceptions. Some CSOs are actually engaged in resource mobilization and contribution to complement government efforts, and we saw the example of Maristops since morning. Advocacy and partnerships collaborations, that is obvious, but also CSOs, many of them, even at that district level, are engaged in social behavior change interventions. They're doing community and individual communications, they're doing life skills interventions, strategic communication, peer-to-peer education, but most importantly, the media engagement. We know that we have community radios, and the people you see in that photo are community health advocates. They're just community people organized into CBOs and are empowered on SRHR, and you can see them sensitizing the communities on sexual reproductive health. So indeed, there is a lot of capacity within the CSOs. Then they create, some of them, this is documented from outside Uganda, some of them have created local committees and self-help groups and work with local gatekeepers. The local gatekeepers include the cultural leaders, the religious leaders, and many of those who may not just take family planning as it comes. They have a lot of questions that need to be answered, and CSOs, a lot of CSOs at the district and community level are having a lot of engagements with these community gatekeepers. Of course, some of them have piloted digital technology initiatives, we've seen, even through Maristops, and many of them, including where I work in SEHAD, we're doing a lot of human rights-based approach into SRHR, and we are capacitating others. And specifically, we are capacitating healthcare workers on using the human rights-based approach to give family planning services that are respectful of everyone, irrespective of age, irrespective of economic status, and so on, and that's extremely important. Yesterday, this week, Minister was discussing, was consulting about respectful maternity care services, and this is where we need to go with the human rights-based approach when it comes to family planning. Youth, of course, we are seeing CSOs, even at the local level there, leading youth and adolescent programming. I won't say much about that. We have even seen example of Maristops. We are seeing them doing community-led assessments and monitoring, and we are seeing the mentoring and nurturing of family planning champions, including amongst religious leaders and cultural leaders, and most importantly, the journalists. What the journalists report about family planning and sexual reproductive health matters and impacts on uptake of services. So that role of capacitating and creating champions, especially in groups like the journalists, the religious leaders, the cultural institutions, becomes key, and we've seen leadership from the CSOs, especially at the grassroots. There is also advocacy to train healthcare workers to provide non-judgmental services. That is basically to do with the human rights-based approach in providing services. Again, you can see how the community groups that are CSOs in districts are taking advantage of community radios to talk about sexual reproductive health and drive demand, as well as dismiss the misconceptions that are created. And when you read widely, evidence is telling us that these kind of interventions by CSOs are actually increasing uptake and changes in knowledge and information about modern contraceptives and other SRHR behavior changes and changes in intention to use contraception, and that's important for us. Also, evidence is showing that modern contraceptive prevalence rate in both rural and urban areas is actually increasing because of the interventions by CSOs. Of course, this is in collaboration with government. There are also changes in attitudes and awareness about spacing and family planning. There is reported better treatment, greater confidence, asking questions, and also better counseling. I think we also saw from the previous presenters that actually there is improvement in counseling services, and CSOs have been reported to play a significant part in this, given that in most of our public facilities, we lack the psychosocial professionals there. I think if we have social workers, they are probably at the district hospital level and not in the lower level health centers, and yet we know they play a big role in terms of psychosocial support, including counseling, and CSOs are actually closing that gap, working with the healthcare facilities. We've also seen reporting of better results in terms of interventions that are focused on reaching individuals, and also interventions that combine the service provision with advocacy and education interventions. So we need to ensure that those three, education, advocacy, and service provision, are actually integrated together. Also, we've seen improvement in access of family planning arising from interventions by CSOs, and client satisfaction has been reported. We know that CSOs have created those strong relationships with communities, and so client satisfaction is being reported. But also there are areas that challenge CSOs to act more effectively when it comes to advocacy for family planning. Firstly, inadequate technical and financial capacity. Some of these NGOs, or many of them operating at the subnational level, do not have the policy documents disseminated to them. They do not have the costed implementation plan for family planning. They don't know what is in there. They may not have the relevant policies there. We disseminate at the national level and stop at that. They would be much more effective if they had such information. Again, inadequate documentation or evidence or assessment of the impact of advocacy. We do advocacy as CSOs, both at national and the local level, but we do not do much in terms of documenting this advocacy and assessing the impact of this particular advocacy. Later on, we don't have indicators that enable us to measure success, and that's important because it's very difficult to attribute advocacy success unless you intention in terms of measuring it. They do not have a central reporting mechanism. The way I had service providers are actually, including private, are contributing to the information management system, the central one. The CSOs, especially in advocacy, are not having any reporting mechanism. So it's even difficult to capture their contribution in terms of family planning. Also, we know that they have a role in pandemics and epidemics. That's an area where we learn a lot. What's the role of advocacy for CSOs when we come to pandemics like COVID-19? We saw what was happening that time. They were not so active in the beginning. They became active later. Did we lose something in terms of uptake of services? We need to answer that. The information gap, I talked about the information gap. They don't know about this information that is relevant. The evidence that has been shared here, those CSOs acting at the subnational level may not have a chance to have it the way I have had it from the presenter here today. And this is the information they actually need to do more effective advocacy. I'm winding up, Andrew. We have fewer CSOs at the subnational level. Most of them are concentrated here in the city center. Of course, there is a coordination and synergy problem. All the speakers have talked about it, that duplication of work rather than complementarity, which we actually need to address among the CSOs with support from the government structures. Of course, even the government family planning structures, the family planning structures are more concentrated at the national level. We have the Uganda Family Planning Consortium here in Kampala. The technical working groups are all here in Kampala. We need to be decentralizing these structures at subnational level for them to also benefit from advocacy. I'll skip the rest and, of course, go to how we can support CSOs to be more effective in their advocacy. Of course, we need to build technical and advocacy capacities, including orienting them and empowering them on the policies and the strategies and so on, because these are the relevant frameworks for their advocacy. Harnessing their potential for innovation. We've seen a lot of innovation through Maristops. Many of them are innovative, and we need to harness that. Documenting and measuring the advocacy efforts becomes very important. Scaling up best practices. CSOs are normally relying on grant funding, which is not sustainable. So they come, a very good intervention, and before we know it, it's done. And we don't do much in terms of scaling up the best practices that would have come through such interventions. Strong and sustainable partnerships with government has been talked about here. And of course, our FP 2030 seeks to maximize contributions of CSOs to accelerate progress towards FP 2030. So we need to create awareness. What are Uganda's commitments on FP 2030, and actually ensure that CSOs acting at that subnational level understand the national goals for our commitments for FP 2030, for them to be able to actually cascade that out into the communities. And finally, we need to strengthen their role in promoting family planning and holding government and holding us all accountable in terms of the commitments that government has made. We need to strengthen evidence about CSOs and what they do and their contribution. And we need to build a strong grassroots family planning advocacy movement among the CSOs, incorporating the duty bearers. And we need to support, build systems and structures to enable the advocacy. And of course, we need to share with them resources for them to be able to do effective and a bit of more sustainable advocacy, and we can expose them to exchange visits, even if it's within Uganda, where CSOs are doing better and causing change. Those from a different district can actually learn from some of these experiences. Thank you so much.
Thank you so much. Let's appreciate Fatih for that. I understand we have questions for her, but I'm going to request that you write your question and you raise your hand. Our team will actually come and pick that question, and it will be passed over to me here. So as and when our panelists are done, I will read two questions that they respond in time, in the interest of time. So in case you have a question for Fatia, with all that she has presented, write it down and you just raise your hand. A team will come and pick that question and we shall have it later. Mr. Walakida, we're going to have a presentation from you about the issues of intervention. Earlier on, you alluded to this, but we want you to kind of dig a little bit deeper in terms of prioritizing the interventions for FP supply chain and financing the FP commodities in that regard.
Yes. The good thing is that all of us have been discussing and have been chatting about family planning financing in this country. And I think many of us in this room are aware that the journey started right from the London Summit in 2012, where different countries were able to come up with commitments, and Uganda is one of those that made various commitments that eventually were packaged into the FP 2020 commitments. And if you can recall from the ICPD Nairobi 2019, the government was able to revise those commitments. And financing is a very critical component where, apart from mobilization of resources from the partners, both domestic and international, the government also made commitments to increase its own financing towards family planning. And at the moment, we have the new commitments, the Uganda FP 2030 commitments, which are very clear, and the government has made a very clear stand on what the expectations should be, but also a roadmap to increase the financing for family planning. Can someone move the slides? Yeah, thank you. I've just picked two slides. I've picked them from the UBOS resource flow survey, just to give us an idea about the trend for financing of family planning activities in this country. As you can see, overall the resources for family planning have increased from 2016. That's about Ugandan in billion shillings, 78.8 to 183.4 billion shillings in 2019. So the last resource flow survey that we did was 2019-2020. So that trend clearly demonstrates an increase in the resources towards family planning activities in this country. The big challenge from that slide, if you see the purple, I don't know whether it is purple on the screen, 87% of the resources are coming from development partners. That's the international. Development partners, you know, donors, international NGOs. They are contributing to that 159.3 is actually 87%. That is a bit of the problem compared to what is coming out of pocket, but also what is coming domestically. Domestic resources are contributing approximately 9%. So that's the biggest challenge that we have. If you look at the government expenditure, this one does not capture the human resource component. A lot of this expenditure is the one that has been going towards the commodities. You realize that the billion shillings from government in the budgets right from 2016-2017 financial year to 2019-2020 has been below 2 billion shillings. And this is, of course, a bit of a challenge for us. If the government expenditure towards family planning is just less than 2 billion shillings. Since we have been talking about commodities, I thought I would include a slide on how commodities, family planning commodities in this country are financed. And if you just look at the last bar, it demonstrates that in 2022-2023 financial year, we need about $29 million worth of commodities to meet all the commodity requirements, putting into consideration the different subpopulations. So from the national quantification that we do, and this one was done in November last year, we estimated that we shall need about $29 million to procure family planning commodities. From the different partners that have made commitments, and I think you can see the list of partners, UNFPA is contributing about $6.4 million this financial year towards family planning commodities. USAID is contributing about $8.7 million. We have a contribution from Global Fund. The contribution from Global Fund largely goes towards procurement of condoms. And then, of course, the GFF AMCHIP facility is still contributing about $2.8 million towards FP commodities. But most importantly, you can see that from the landscape analysis, we have a funding gap equivalent to 30%. So when someone talks about stock out of commodities at the health facilities, the reality is that we don't have enough resources to procure all of the commodities that we require in this country in a year. We have that funding gap of 30% that we need to close using different mechanisms. I picked this slide from the draft family planning financing strategy, which is almost similar to what is within the health financing strategy. Uganda has a health financing strategy, but also have a draft financing strategy. When you just look at this slide, it is very evident that we know what to do, but also we know where the resources should come from if we are going to close the financing gap for family planning activities, not only the commodities, but overall. We need to intensify efforts to mobilize resources. And also we need to innovate. Most importantly, we need to innovate. As we are mobilizing resources, we need to adopt innovative approaches to get resources. You can see that there are various mobilization approaches that we really should be adopting to increase resources for financing mechanisms. And of course, the first one is out of pocket. We know that largely family planning commodities in this country are given free of charge. And the government, many of them come through the national warehouses, national medical stores that takes care of the private, the public facilities, and then joint medical stores that serves largely the CSO facilities, the private not-for-profit, and some of the accredited public health facilities. However, we know that if we segment the population well, there are people like those in this room that should be able, that have the ability to pay for their methods. So why should we have people in this room getting the free commodities? So if you introduce and roll out the total market approach and you segment the population well, then we should be prioritizing the free commodities for the sub-populations that are not able to pay. I think for us, many of us have been talking about National Health Insurance Scheme, and I'm just hoping that probably this year, something magical will happen. In the joint review mission, those of you that were there, the health sector review mission in Munyonyo, the minister promised that this month, we are going to discuss it, we are going to introduce it to cabinet. Maybe before this month is going to end, is it on Sunday? Maybe something will come up and then it is presented in Parliament. You recall,
we shall pray.
Yes, the bill had been passed by Parliament, went to the President, came back. Of course, you know very well what happened. I don't want to tell that story. But if we happen to move towards the National Health Insurance, that's why I said we know what works. Overall, I think all of us know from the housing survey, household survey 2019-2020, the insurance coverage for this country, the population covered by health insurance is only 3.9%. But of course, you know that many of the schemes, the insurance schemes, are not incorporating family planning. So if you need a family planning commodity, it's not covered by health insurance. So that is a problem. Of course, the same applies to many of the community-based insurance schemes that we know. And of course, a lot of advocacy work has to be done to get those incorporated. There are ways that have been suggested. For example, apart from advocating at national level for the government to increase domestic financing, which is more sustainable, what is it that should happen at the subnational level? Local governments, how do we entice local governments to commit some of the domestic resources at that level that they mobilize towards family planning? And I know some of the partners have tried JAPIG has tried the TCI, the Challenge Initiative. It's a good initiative that motivates local government to commit some resources, but also overall the private sector. Private sector has a corporate social responsibility. How do we tap into that to be able to finance some resources towards family planning? And of course, the last bit I need to mention is the multi-sectoral approach, the mainstreaming of family planning into the different sectors. If you talk about family planning, the biggest challenge we have is that when we are discussing family planning, like in this room, how many are coming from Ministry of Education? By show of hands. How many are coming from Ministry of Gender? How many are coming from Ministry of ICT? You can't deal with issues of stock out when ICT is not there. When we are talking about electronic logistics information management system, we need ICT. How many are coming from Ministry of Public Service in this room? They are not there. How many are coming from Ministry of Local Government? They are not there. How many are coming from Ministry of Energy? Many of our health facilities are not connected to the national grid. So if they are not connected, then these electronic systems that we are talking about, colleagues, unless we mainstream family planning in the different sectors, we may not be able to address most of these challenges that we are talking about. UNFPA, for example, has come up with some of the innovative approaches, to engage government, to entice them, to be able to contribute some more resources. We've just signed an agreement, a compact with government, Minister of Health, and I appreciate Dr. Mugai has been very supportive in ensuring that government actually signs this agreement. Government, through this agreement, is going to have a mandatory contribution. For example, UNFPA, if in a year UNFPA says we are going to procure commodities worth $6 million, there is a mandatory contribution the government is going to make. And the Minister of Health and the Minister of Finance have signed this agreement.
So the key word there, Mr. Walakira, is mandatory.
Yes, it is mandatory. So if UNFPA is going to give commodities to Uganda, the government must contribute that percentage. And within that agreement, there is also a component called the matching fund. We have told the government that, we can match any additional resources that you commit towards family planning. For example, we had in the GRM, the Commissioner for Planning and Budgeting indicated that I think in the next financial they are committing additional $3 million, it is 3 billion shillings towards family planning. So if government makes those commitments and we are putting in additional 3, UNFPA is going to match that. So we have been telling them, if you commit more, we shall commit.
Thank you so much, Mr. Walakira. In the interest of time, I'm just going to hold you there. In the interest of time, but we're going to have more questions coming. Amanda, can you hear us? Amanda is online. Amanda, can you hear us? Amanda, you're online. Okay. So yes, Amanda is going to present to us something to do with the gaps in the FP service delivery for adolescents and the youth and the proposed solutions. Amanda, I don't know if you can use just 7 minutes to make this happen. We're waiting for a miracle at the end of the month in terms of health. Let's say miracle starting with you, Amanda.
Wow. Thank you very much, Andrew, and good afternoon to you all members in the House. My apologies for not being present there, but I hope it's all understandable. I'm still with you all physically. And just to go straight to the point, it's lunchtime, very tricky time for me to speak, but I'll quickly go into the gaps.
Amanda, can you hear me?
Yes, I can hear you.
I have a request. Can you tilt your phone in a landscape beat for purposes of the screen here? Just turn it in landscape, please.
Okay. I'll be upside down.
Okay. We can go back to portrait then. It's totally understandable. Apologies.
Yeah.
Carry on, dear.
Okay, thank you very much. I hope this is going to be better now. Yeah, I'm using my phone for purposes of environment and all that. I couldn't use my laptop. But nevertheless, I just had to make it for this partnership engagement. And straight to the point of gaps in family planning service delivery for adolescents and young people, youths. I'll start with, many have been mentioned and hinted on from Bonnie's presentation, and Dr. Olakira just hinted on some, and also Miss Fatia also mentioned some of the challenges. So we'll start with provider biasness. Many a times I've been approached by young people saying, that the providers in that health facility are biased, like don't want to talk about family planning with young people or with us as adolescents because they feel we are too young for that information. Like, okay, yeah, that's one gap that we need to address. Then there's also less or misinformed providers, if I could say. They have little knowledge on family planning. In some facilities, that is very true. So we talk about family planning, yes, but the knowledge, the level at which the service providers have knowledge about the family planning commodities, leave alone knowing the word family planning. But in terms of the commodities, the usage, and the side effects, talking about all that, the level of knowledge is very, very little. And then we also have adolescent biasness. So biasness comes on both sides, from the service provider's side and from the adolescents or youth side. Many young people today, I want to use the term young people to address all of us, adolescents and youths. So many young people have biasness towards family planning. First of all, the news that is spreading around in social media, someone took pills and died, then maybe the side effects that they're talking about. So young people today are drawing a setback. They're like, no, I don't want to go there. And then the other thing is, it's like a survival tactic. Like, okay, so I'm a child-headed. I have a dependents, like 5 dependents to take care of. I'm the head of the family. I'm 18. I'm 17. And then the only way for me to get money or to be able to sustain myself and the people I'm living with is through sex. And this loaded guy is going to come to me and say, I can give you 100,000, 50,000, and that is like enough to sustain me for a whole week or even a month. And he's giving me a condition: we're going to have sex without a condom. And yeah, that is what my condition, and I'll give you the money you want. So I'll weigh my options here, and I'll be like, but if I tell him to use a condom, he's going to send me away. I need this money, so I'll go in for that. So that kind of attitude in our adolescents, in our young people. We also have a gap in integration of information. When we talk about family planning, we're always talking about it alone. The HIV sector, they're always integrating. You'll find, like at the Adolescent Health Clinic in Mulago, they're talking about life skills, mentorship, and HIV medication and stuff like that. It's really a combust environment when you visit that clinic, and which we do not have when we talk about family planning. It will be strictly family planning, and that is why it is still holding back. So we lack integration of our information with other elements or aspects of life, entrepreneurship and all that. The other gap I would talk about is inaccurate commodity use information. So a young person will find out this adolescent has heard from friends that pills can help you not get pregnant, and he has not specifically found out which pills. So they will go and buy the daily pill, the one that's taken 1-1, and be like, now I'm going to have sex 3 times. Let me take this whole strip without actually going into, because they fear to inquire about the usage, because they'll be judged first of all. So they will decide to take matters in their own hands, and you find such things happening. So that's commodity use information. Lately, I've got reports on inactive toll-free lines. So I would like to say, I recognize the presence of Naguru Teenage in the house. Richard Hand, Uganda. I saw Benson. Then Minister of Health, thank you. But a particular complaint came to Minister of Health. The toll-free line that is being provided, sometimes it's off, and then it's not 24 hours. And when someone answers, they are rude. And so someone will end up, the young person who has called will end up like, no, I was just checking if the number works, and hang up. They have not really expressed themselves or what the reason why they have called. And then remote areas of accessibility. Just yesterday, I think, Andrew, you also witnessed, you read the news last night, Sembabule has closed 2 health center 2s because of no supply of medical commodities or medicines. And so you find that this Sembabule, those health centers were closer to the people. But now they have been closed. Where are the people going to go? It's very far. That is one case. Look at places like in the Karamoja regions. Look at the places in West Nile, Madiokolo, Terego. Sure you are, if they are listening in, they're doing some good work, and Naguru Teenage Center as well. If you look at the populations there, the young people, and the distance from where they live to the health centers, the nearest health centers, they are very distant and very far from each other. So the remoteness of services for the adolescents is another gap. Climate change effects. We have a very different climate change right now going on. Many things are happening. We have flooding, other places are so dry, so there is no food. All this is contributing to service accessibility and service delivery for the adolescents and young people, where they come from and where they live. And if you need me to clarify more on that climate change effects and as a gap, I will. But for time, I'm going to just rush through the gaps I have. I have like a long list, so let me just go straight through it. And then we have the unemployment rates growing. No one doesn't know about that young people are not employed. If someone has finished senior 6, they have even graduated, finished university, they cannot get internship placements. Even if when they get the internship placements, they're not taken up after the internship period is done. So they are left stranded. And you'll find that this young person has no job. Even the internship transportation from their home to the place of internship was being given by the mother or the father, or even in the absence of mom and dad, they are getting transport from friends. And these friends are going to maybe push them out, push them into vices or acts that they are not willing to do, but because the situation presents, they will be forced and tricked into going into the commercial sex work, like sleeping in exchange for something, sleeping with men. And so it all rotates around unemployment rates that are rapid today and growing. And then low self-esteem among our adolescents. I remember when I was at school, we used to have people visit when I was in primary school. And some of these people, I remember there was a very famous doctor, Dr. Kakorachi Alex. He was, I think, part of Straight Talk. I don't know. Then I later met him. He was part of Maction Bay Hospital. But by that time when he came, it really motivated me because the information, the level of information he had, and then the ladies that came with him, they really motivated me to really speak out and be brave and speak my mind and learn to stand by my word. I think that is not the case today. Everyone is like, to my own business, and you care for yourself and for your family. That's it. No one is there to mentor, to motivate, to inspire, apart from now those who can access social media. They get inspiration from their role models. Like, I'm very sure that Dr. Sabrina has really inspired many young girls, many young ladies out there. But she's one of the many, and we need more inspiration and motivational people leave the social media platforms and come physically into schools and into places where these young adolescents are always dwelling, to give them that self-esteem. Age-appropriate information. There's a time when Dr. Richard Mugahi, my commissioner, is over there on the panel. He mentioned that we cannot give like the information we give to a 10 to 14-year-old is not the same information we give to a 15 to 19-year-old, which is so true. So today, with the growing accessibility to internet, you cannot really target that information in that same way. The 10-year-old might shock you today with the level of information they know that you do not expect they know. So I think we need to be open a little bit and recognize the fact that we are not the only teachers. And yes, if we have failed to instill the values in our children from home, someone else will instill other values in them from elsewhere, and those values might not be resonating with our values. So that I'll leave the age-appropriate information at that. And non-functioning policies is another gap that we have. We are very good, and we have very good policies as Uganda, as a country. But most of these policies are remaining up there where they are discussed from, reviewed from, and passed from. They never get to be trickled down. But I love the fact that our ministry and partners are moving forward to another step of while disseminating some policy documents of interest, they have to take a package of other documents. So I'm looking forward to what that will do. That is part of a solution. How disseminating a whole range of policy documents together as a package will help in addressing some of these issues that adolescents are facing in terms of service delivery and accessibility. Then we have organizational intercoordination. You'll find that, for example, Richer Hand is doing well in some region, and then you'll find also UWAF is in the same region doing almost the same work. You will have Naguru in the same region doing the same work. We do not have like a coordination mechanism to have our work synchronized. And I think when we work together, we join hands together, we can really make a great impact and reach miles together, because there we'll know we're harmonizing our programs and we are going to reach more, and we're not going to have repeated work in one place. Then we have data mishaps. I think currently we have that element is being worked upon and it's improving, but before we didn't have segregated data between adolescents, knowing that how many adolescents are accessing services, how many adolescents are dying due to maternal childbirth, mortality and all that. But now we're seeing a difference into that, and we're hoping to trickle that down to the grassroots and local levels, because it's still at national level. The other challenges, I have like three more.
Amanda,
we used to have youth friendly. We had to get the VHTs to help out in service delivery. Now, my solution would be getting youth VHTs as well, because they are peers to their colleagues and adolescents, and they can easily speak the language and also understand better. And I'm sure the young people will be happy to and freely be happy to open up to the VHTs if we incorporate the youth in the VHT system. We need refresher trainings for the providers at all health facilities, especially public health facilities, on adolescent responsive services. That will go a great mile to address the problems of biasness and misinformation. We need to integrate our SRHR programs with climate change action programs, life skills, income generating activities, and I think that will go a great mile in addressing some issues. And even with some organizations of programs that already have the income generating activities for adolescents, we need to go an extra mile to do follow-ups, do check-ins, maybe if they need capital, motivate them, get them customers. That way they inspire others. Then we need a method mix from the facility requisition level, because if facilities request for the method, the commodities, the SRH commodities that they educate about to the adolescents, and they have them ready and available at the facilities, I think NMS or the other warehouses don't have a problem in disbursing those commodities to the facilities. So we need to check into that. We need to expedite the existing policy documents to have them functional, and that will also help in addressing some legal matters that we have, especially with teenage pregnancies, child marriages, and unsafe abortions. We need to reinstate our youth corners and have them well equipped with all services to make them comfortable, for adolescents to dwell and spend their time. And with that, Andrew, I would like to also just add in a disclaimer that our schools, especially our public schools, are no longer safe places for our children. We might send them always there for adolescents, but they are not the safest places we have today, because we have many teenage pregnancy cases coming from there. With that, I'd like to submit. Thank you very much,
Thank
Andrew.
you so much. Let's appreciate Banura there. I want to appreciate all of you who are here, and I'm sure we have done it the English way. Each one of us, apart from the panelists here, you have your lunch coupons in you. That is a sign that we are about to get done. And a couple of questions have come through here. One came in for Fatia from Diagoba Moses, Assistant DHO, says how best can CSOs support districts come up with DCIPs? That is the question there, Fatia.
Hello, thank you, Moses. I think, again, as part of the relationship between the district health structures and the CSOs, I definitely think the adaptation of the costed implementation family planning is a good suggestion, and definitely I think that's an area that is of good potential for collaboration between the CSOs and the districts. I think if it came, of course, as an advocate for budget allocation, my first point of advocacy would be that let us integrate that in the district health budgets. That would be my first number one advocacy point, but also we can engage with CSOs and see how we, the CSOs, can make a contribution. But my first contribution would be to advocate that they're included in the district budget allocations.
And the follow-up question was, why are CIPs having a short lifespan? Why CIPs have a short lifespan? I think that will come to the doctors here. Let me send this to Mr. Walakira. He says that like any other guideline, why doesn't the district have the district family planning working group don't come up with a district guideline that can be used by all other districts?
Yeah, thank you. Again, I don't know how many of us have been in this area of family planning. We are aware that Reproductive Health Uganda supported the ministry to develop guidelines for strengthening family planning at the decentralized level, coming up with focusing on the multi-sectoral engagement, but also guidelines that encourage districts to have working groups at that level. Some of the districts actually have multi-sectoral FP working groups, and which is a very good idea, but a number of them don't have. So that guidance is there. I want to say that during the COVID, and this is an idea that we can borrow from COVID, some of the lessons. You remember we had district task forces at the district level, but also we had subcommittees, for example, on continuity of essential health services and many of the others. And we saw different partners in a coordinated and multi-sectoral way supporting those subcommittees to function. And I think the challenge here is for us to have the operationalization of the FP working groups at the district level. And of course, my advice is that these should be multi-sectoral working groups because of what I talked about, that we need the different sectors to be involved.
Thank you so much. Dr. Betty, we want to understand how are the districts dealing with the lack of FP products? Because I don't know the magic you guys do at the district level, but the stockouts, I'm sure that it's such a huge challenge you're facing as DHOs.
Yeah, thank you very much, Andrew. So really what I'm going to share is an experience of Bunyangabo district. Bunyangabo is a small district in Midwest, around 35 kilometers off Kasese Road from Fort Portal town. So there are a lot of things that can be done, but I want to specifically zero myself on the contribution of the public sector support, how it actually helped us to address the issue of commodities in our district. So our journey with the Maristops and public sector support program started in 2020. And there were very many other things which we did together, but the most important was strengthening the supply chain. And this partnership came at a point where ministry was moving towards the one facility, one warehouse policy, and of course introducing the use of electronic ordering systems. And at that time, we were really not so much well versed with this kind of arrangements. So what we did was to first of all identify people who could be mentors at the district level, train them, then move ahead to train our health facility staff, especially those who are responsible for keeping stores. In our districts, especially level 3s and below, you realize we do not have somebody who is really there assigned for stores. But we have gone ahead to innovate and assign duties to people whom we think can manage. Many of our facilities have the records people who are doing both the stores and doing records. But of course, in some, like level 2s, and even some level 3s, you identify somebody who can do the job, because some of the records people, they may not have interest, or either they don't have the capacity to grasp to do things. So we identify somebody who can be able to do this. So what we did was, first of all, to train these people in how to quantify and, of course, order on a timely basis. And Andrew, I can tell you this has, I think you saw from the previous presentations, it has improved the issue of stock levels and, of course, minimize stockouts. But, of course, notwithstanding the challenges which my neighbor just mentioned here about deliveries, those ones, they are beyond our scope. But within our means, we have tried to ensure that the orders are made timely and people were able to quantify the orders based on the data that is available in the facilities. I'm very sorry if that is sustained. We are going to eliminate and, of course, minimize the issue of stockouts in our facilities.
Thank you so much, Dr. Betty.
Yes.
Dr. Mgahi, why are the CIPs having a short lifespan? Then Dr. Mulwani Elisa, the DHO of Dhaka, says that what are you doing about the male engagement? The population of this country and the fertility rate can be dealt with if we put men or male on board. What are you doing about that? And the other question is, how can we improve on the DHO management of FP side effects which seem to reduce on the DHO uptake? On the uptake. How are you improving on the DHO management of FP side effects, which affects the uptake later on?
Okay, thank you, Andrew, and all those who have asked the questions. On the issue of a short lifespan for our policies, I agree with you, but the biggest challenge has always been the time space between 5 years is not very short. It is based on science that a number of things change over the 5 years and would be appropriate to update. We don't change the CIPs, we update them. We look at the original document, and if there's new emerging evidence, we actually update. So it is appropriate. The only challenge is that it takes 1 year to update, another year at the headquarter, then it reaches the district in the 3rd year or 4th year. They need to customize it when it's expiring. So those are the policy practice bottlenecks that I was talking about and that we need to address. And good thing is Dr. Kabanda is here, and we shall be able to work on some of those bottlenecks. Very quickly on the drug shortages, I just wanted to add that there is a redistribution policy you can be able to get supplies from one facility to the other, from the Ministry of Health, even from one district to the other. Of recent, me and Walakira worked out from one country to the other. So we exported some supplies to another country, though we are not the manufacturers. So it's a redistribution instead of having wastage, and I just want to make an official communication here that for those districts that are lacking a uterotonic called oxytocin, we have it in abundance at joint medical stores. And joint medical stores also is able to provide you with emergency supplies of family planning in case NMS has not supplied. And please, I encourage us to utilize this alternative distribution system. Male engagement, DHOs and ADHOs, as I mentioned, the center sometimes does its work and it's not well disseminated down. There is a male engagement strategy. We agree with you that men must be well involved at the center of family planning. We have seen this over time, and I called Walakira yesterday. I told them, why do you always leave out men? The good thing we are 4 of us here. So family planning is at the top. So in that context, there is a male engagement strategy. We have printed out copies. Partners can pick them from either Dr. Richard Kabando or myself. We can have them distributed. We are working on even updating it before it reaches you. We are adding some more things, so the male engagement strategy is available. How are we supporting DHOs to manage side effects of family planning? I think there are very many, there are many pieces of literature about the side effects. For me, I've been a DHO before and I understand what it means. But the most important thing here is the DHOs who are here, you need to profile. I think it's saying go. We need to profile those side effects and be able to speak about them. You routinely get airtime space on radios and so you need to be able to provide this information, talk about family planning, and the presence of the family planning technical working group at district level actually makes this work better, because it's not only the DHO or the ADHO. Next time take a certified client, next time take someone who had side effects and was managed, so that we can have the communities appreciate that it's not you, the healthcare worker, marketing this. In the new CIP, as I conclude, family planning is no longer a medical issue. Family planning has been positioned as a development issue. We don't want medics to medicalize, the nurses to medicalize family planning. You're only offering supplies. And these supplies can even be offered by clients themselves. There can be self-administration of family planning. So the new thinking is demedicalize family planning, position it as a development issue, let it be led by a non-medic. For us, we are managing side effects and supporting the other systems. So that's the new thinking, and that's how we need to rethink family planning. Thank you so much.
Thank you so much. Let's appreciate my panelists, ladies and gentlemen. Online, what I can see, the Bugalus are going low because we are in that time of lunch, but don't worry. I want to appreciate a couple of you who have been tweeting the conversation from this room. Livia, Uganda, I want to appreciate you. I want in a special way to appreciate Omuge for being part of this conversation, and those following this conversation online, and you're part of it. Ladies and gentlemen, let's appreciate my panelists as they take back their seats for our very last engagement. One more last item and then we shall go for lunch. It is quite challenging to hold people for all this. Thank you so much, Mr. Walakira, for holding you for all these hours. I really want to appreciate your patience to this agenda. This time, allow me, we already had a group photo for all our participants who are here earlier on, and those who have been online. I want to appreciate you in a special way. But as we are closing this, my biggest prayer was that by 2 p.m., that is the max time, we could actually have these closed. Allow me to welcome the Commissioner, Public Health and Prevention Promotion, Dr. Richard Kabando, HTU as well, to come and give us the closing remarks. And then we shall head for lunch. Let's welcome him.
Thank you, Andrew, the Senior Country Director for Maristops, and all your top management team, my colleague from Ministry of Health, our dear partners, our senior colleagues from the districts. Good afternoon. I know you're hungry. I'm actually very hungry. So I will not take a lot of your time. But I would like to thank Maristops for, first of all, for inviting us. And also given the fact that the topic of discussion was more skewed towards strengthening the public sector. My expectation is that most of the key presentations would be anchored on that area. And of course, to rally also more other partners to ensure that public sector engagement is one of the key areas of concern and should form part and parcel of the work plans for all institutions. Because without the public sector, it means that policies, strategies, and guidelines will not be developed. That also means that the frameworks in which you implement your programs will definitely be very weak. So it's a good gesture, and of course, given the fact that for us work with government, getting feedback, especially on strong areas that we need to maintain, is really very, very crucial for us. But of course, also highlighting weak areas where we need to strengthen is good still for us. This whole week, those of you who on Twitter, you are following the Uganda Health Exhibition. And right from the word go, my responses were that this is a good gesture for us. Because to many people, when they talk about health, they tend to think about Ministry of Health. They tend to forget other MDAs that have a bigger role to play when it comes to healthcare service delivery. They don't even think about Minister of Finance that has the biggest part to play. So people don't discuss what we call the problem of the problem in academia. People look at problems at surface level. They don't dig deeper where the problems are originating from. And for me, it's a good feedback mechanism. Ideally, the health sector should invest more in getting feedback from the public. We should be having a budget for that. So if we have people in the Twitter space who are doing that work for us, it is something that we should take positively. So when we come here, especially if the theme is focusing on public sector engagement, I think it is something that we need to embrace and look more into many more issues. Allow me end with two key issues. One is on FP reflections, more so in the area of demand for FP services. I know that 90% of the people who are here are experts within the FP space, including Andrew Chamagera actually, including the media. For Andrew, since last year actually wanted to front Andrew as one of our FP male engagement champion in the country. Now that we have many FP partners here, we even wanted to have a budget for him to do for us some good work. This is something that we can discuss over. And someone asked about male engagement, something that we are trying to revitalize, and I think we should be able to have discussions with partners on how best we can have male engagement for FP as one of the key areas of concern. But the reflections on, I had put some notes here, but it's good that Dr. Mugahi talked about it briefly. Medicalization of public health interventions, now that we're talking about family planning. I don't want us to leave this only in our documents. My request to you, Carlo, is that working with other partners, let us have discussions on how best we can demedicalize family planning so that we swing into action. We need to take this back to the communities. FP in Uganda, where we have many cultural institutions, is taken as a social cultural issue. Me, I have 5 children, 4 beautiful girls and one boy. But wherever I meet my elders, they think I'm not serious. In their thinking, they say, Richard, you have made some money, you cannot afford to have only 5 children. You are very lazy. So it is challenging. So they look at it from that perspective. It's a social cultural issue, so we need to tackle it from that angle. In terms of messaging and engagement within the communities, given the fact that many of our communities or families, people are still poor, we need also to look at it from the socioeconomic angle. For me, those 2 areas are very crucial in increasing uptake for family planning services in the country. But even when you do census here, you realize that majority of the people here are coming from the health sector, or what they are, the kind of work they are involved in is actually inclined to health. It is something that we need to think about and have some key engagements. We need to take this back to cultural institutions. Me, who comes from Uganda, I would like to see the Kingdom of Uganda championing this entirely. Mugahi, who comes from Toro, would like to ensure that these kingdoms are supported financially. In our programming and budgeting, we need to find ways how best we can support these institutions to take up this issue to the grassroots. Otherwise, if we don't bring religious and cultural institutions on board, chances are high that our efforts will not be able to yield the results that we want to see. And then lastly is we need to deliberately advocate for the inclusion of young people. I find a lot of difficulties approving content for the young people at the Ministry of Health. Every time we approve content, you find some groups of people protesting, but we cannot keep quiet when 70% of our population comprises of young people. We need to do a lot of advocacy, actually. Beyond Parliament, there are other key sectors or key individuals who have a big stake when it comes to messaging, especially among young people. People are having sex at the young age. We need to open up. So they should know that people are having sex at the young age. And we cannot keep quiet about some of these things. We need to open up. We need to have deliberate efforts of ensuring that advocacy for FP messaging among young people is very central, given the fact that our country comprises of young people. With that, allow me to take this opportunity to have this partnership engagement officially closed for God and my country.
The key takeaways for me is that we have already 2 in the kingdoms, where Dr. Richard Mugahi happens to be the Minister of Health in the Toro Kingdom, and is already here and is part of us. Let's give that a round of applause. So the mandate then we give you, Dr. Mugahi, is to talk to the Rukidi that this is the agenda, that we can use your structures to reach the people. And Dr. Kabanda, who is here, who is a Wechtiwa, he equally sits in the Luchiko of Buganda. We equally request that the same message goes up to the Katikiro of Buganda and even other regions. That said, ladies and gentlemen, let me request that we all stand up and the DJ sounds the two anthems in the rightful order, and then we shall go for lunch. Thereafter, we shall leave at leisure. Let's all stand up for the national anthems, please. Can we have the anthems sounded? Ladies and gentlemen, thank you so much for coming. Let's clap for Maori Stops Uganda for the 30 years. As we're going for lunch, let's interact more, let's talk more, let's network more, and keep working together with Maori Stops Uganda. Have a lovely afternoon.